Going live in 5, 4, 3, 2, 1. We are now live.
Good morning. You have shared your screen? Good morning, friends. We are ready for the part 3 of OT is my temple. And this is a wonderful webinar series conceptualized by Dr. Wasudeo Gadegone. We had 2 episodes and this is the third one. We have wonderful topics today. We have with us Dr. Babhulkar sir and Dr. Rajeev Raman as panelists, and we have a faculty member including Dr. Shivashankar, Dr. Pradeep Kothadia, Dr. Rajendra Abhyankar, Dr. Maruti Lingayat, Dr. Prakash Sigedar, Dr. Sarang Deore, Dr. Unmesh Mahajan, and along with me, myself, Dr. RM Chandak and Dr. Girish Motwani will be moderating this session. Over to you, Dr. Gadegone, sir.
Good morning to everybody. Welcome to Ortho TV and Maharashtra Orthopaedic Association webinar on OT is my temple part 3. We have a very intelligent and respected faculties till now, and today we are having a senior most respected orthopedic surgeons of Central India, Dr. and acclaimed all over world, Dr. Sudhir Babhulkar and Dr. Raman from Orthopaedic Association of West Bengal, Calcutta. They are the senior most persons. They are going to guide us and putting us on right path of the OT is my temple third part. So I request Dr. Babhulkar sir to give a message to the Maharashtra Orthopaedic Association Veteran Surgeon Forum. OT is my temple. Over to Dr. Senior Babhulkar sir.
Good morning, everybody. Can you listen to me?
Yes, we can listen to you, sir.
Good morning, everybody. Now, this is the third session, not the episode. Episode, that means something wrong in the OT. So this is the third session of how to respect our OT. Now, with the rise in the infection rate, it is important that you take the care right from the beginning. So it starts in the OT, and every day some improvement is coming up in maintaining the discipline of operation theater. I think every person would be benefited by this webinar. I expect good thing to come out of this webinar. All the best to the speakers who are going to contribute their thoughts in maintaining the hygiene of the OT. OT is my temple. Take care. Over to you, Dr. Chandak.
Thank you very much, sir, for those words of wisdom. Dr. Raman sir, Rajeev Raman sir, if you would like to address us.
Thank you, Chandak sir and Gadegone sir for invitation. I think MOA comes with a new concept every time, whether it was office orthopedics or OT is my temple. These are the new initiative, I think, and every time it comes from Maharashtra Orthopaedic Association. And there's lots of learning in this. And thanks MO for organizing this unique webinar, because such type of webinar has not been organized in the past. And thanks to the whole team. And thank you to the team MOA for your kind invitation.
Thank you so much, sir. Thank you so much. With everyone's permission, I would like to begin the first talk. First talk would be Dr. Shivashankar sir. He would be talking on radiation safety. Girish, if I can have you on board.
Dr. Biraris is also there.
Welcome, Dr. Biraris. Yeah. So I would.
Good morning, everyone. Thank you, sir.
Good morning. Welcome. So I'll be sharing the screen. Welcome, Dr. Shivashankar sir, for your talk on radiation safety.
Chandak sir, we need to share the voice also. Share voice.
Yeah.
So before sharing the screen, we need to put a click on share voice.
Okay. So you're not able to hear his voice?
Yeah. No.
No, we are not.
Okay.
So before sharing, there is an option on the left, share voice.
Okay, just a minute. Girish, you are able to hear now?
Sir, the screen is not shared yet.
Oh, I think by mistake Chandak sir left, I think.
So did you get the option, share voice?
Sir, anyone else has the presentation by Dr. Shivashankar?
It is with Dr. Chandak only.
Okay, I think sir got left accidentally.
No, sir, he's trying. He's rejoining.
डिपार्टमेंट का पासवर्ड क्या है? लिंगायत स्मॉल का
Kothadia sir. Kothadia sir.
Yes, I am ready. Bolo.
You start your presentation till meanwhile we will try to do something.
Okay.
So just give us 30 seconds.
Okay.
Internet fell down and I just got disconnected. So I'm just
No
sharing.
problem.
Yeah,
Okay.
I'm just sharing again. So Girish, I have shared. You have to share sound.
Yes, sir.
So
First,
you
share
have
the
to
sound.
click share
Yeah.
with sound.
Okay.
Yeah, I'm just sharing.
Yes, sir, it is happening.
Yeah. Just let me know whether you are able to hear him.
Good morning, everybody.
Girish, this is fine.
At the outset, I
Yes.
must thank the
Okay,
Maharashtra
sir.
Orthopaedic Association for thinking
It is
about
working,
this
sir. Thank you.
wonderful
Thank you.
topic of Putti is my temple. I'll be restricting my talk to radiation hazards. Friends, CM is a necessity nowadays, and every orthopedic surgeon requires them. And hence, as orthopedic surgeons, we are exposed to radiation hazards. So we will be discussing how to reduce them. By using CM, one can do better quality work, but one should not fear about the radiation hazards too much. And that's the reason why I'm giving this talk on how to reduce radiation exposure while doing orthopedic surgery. There are some terms like RAD and REM and Roentgen. They're almost equivalent and can be used interchangeably. Sievert is the amount of ionizing radiation measurement. So this is a useful unit. In the next 10 minutes, we'll be answering some of these questions. 6 inches or 9 inch CM, high frequency, low frequency, what is ALARA, how far is far, etc. How a CM works. There is an X-ray generating unit which generates the X-rays, and the IA or the image intensifier has a fluorescent plate on which when the X-ray falls, the image glow happens and the CCD camera captures them, and it is intensified by the intensifier and it is converted into video signals, and on the monitor we see the picture. There are two types of storages. A simple storage which can store about 100 images, and better one is a computer-based storage. You can save all the images. There are basic controls over the body of the CM. One should know all the switches there. Coming to the first question, 6 inches or 9 inch. On the left, it is a 6 inch of the hip, and on the right, it's a 9 inch around the hip is taken. Definitely more area is covered, so it's easier for the orthopedic surgeon to look and count a vertebra or see the other parts of the body or larger area can be seen. And that's the reason why we should go for a 9 inches CM. Low frequency or high frequency. Low frequency, the radiation fluctuates, the quality of the image produced is poor, whereas in a high frequency, the radiation frequency fluctuates at a very high level, and hence the quality of the picture which produced will be better. So one should go for 9-inch high frequency CM. How far is far enough? As you are away from the beam of the radiation decreases. So if you are about 50 centimeters away, the radiation will be only 25% or 1/4. If you are 1 meter away, the radiation affecting you will be 1/10 what it affects in the center or the beam. So one should stay as far away as possible, at least 3 feet away from the main radiation beam. How to position CM for less radiation to the operation theater personnel? X-ray tube, if you keep it above like this, when you take an X-ray, a part gets passes, the primary beam passes through the body, and partly it gets absorbed and partly gets transmitted. The transmitted one forms the image, and for a thicker person, more radiation is required to form a better image. Partly it gets reflected, that is called the divergent beam, or the secondary image, or the reflected radiation. So we are more concerned about the secondary beam or reflected beam which comes from the body, because the primary beam passing to get a good image cannot be altered by you or me. So when the radiation is when you are using the CM, partly it gets absorbed and partly get reflected. Reflected is one which is secondary radiation, and refracted is the one which forms the image, and you see a good quality picture of the CM. Normally, on the left top picture, you can see that the X-ray gets reflected by hitting the table. So you should keep the X-ray unit under the table, and the II should be above the patient in this fashion to reduce. If you are keeping the X-ray unit above, you can see that the radiation, scattered radiation affect the theater personnel. So that is wrong. So better to keep the II above and the X-ray tube below. Similarly, when you're standing as a surgeon, stand on the side where the receiver is there, not on the X-ray side. On the X-ray generator side, there will be scattered radiation, whereas on the opposite side, there will be less amount of radiation. So better to stand on the opposite side. So we said that the X-ray generating unit should be under the table, but majority of us use the IITV itself as a table to operate, especially on hand and elbow. Is it a dangerous practice? So this article by appeared, which in JBGS in 2001 said that if you are using X-ray CM itself as a table, especially for smaller parts like moving parts of the hand and wrist, then it's reduces the radiation. The reason is, if you keep the a body near to the X-ray tube, only less amount of area will be seen. Whereas if you keep the hand on the image and inspire, more area can be seen. So better picturization happens, repeated shoots are avoided. So it almost has reduced the radiation by 60% if you are using in a small moving parts, the X-ray itself as a table. For a normal position for thick parts, you should use the II above and the X-ray unit below, because the radiation is more, the scattered radiation should be, because of the thick part, scattered radiation is also more. So you should avoid taking the X-ray generating unit above. But whereas for small parts and moving parts, it's better to keep the II down and use it as a table. Now we'll be worried about how many surgeries can be performed every week. So for 1 year, the permissible radiation is 5 R or 5000 millirem. So a study has been done which says that maximum radiation happens while doing spinal surgeries and interlocking nailing surgeries. Even in interlocking nailing surgeries, femoral nailing took 7.6 minutes, whereas tibia nailing took only 2 minutes. So maximum radiation happens during freehand distal locking. This article by Sanders in 1993 JBGS, they talk about maximum radiation while doing interlocking nailing only happens. Still, a surgeon can safely perform 750 nailings per year. Means almost every day you can do 2 nailings under CM without any worry, provided you are using all the safety gears like this as shown in this picture. The next one is, what are the hazards of the radiation? The various tissues are responding to the radiation differently. Embryo and fetus have the maximum sensitivity compared to the other tissues like CNS, nerves, and tendons. So there is somatic hazard like cataract happening over long course of time, carcinogenic effects on the body like thyroid carcinoma, breast carcinoma, bone marrow depression, lungs, skin, etc. It can also affect genetically and cause mutations, and also can cause problem for the individual descendants. Then chromosomal abnormalities can cause spontaneous abortion and severe birth defects also. The radiation hazards are classified into stochastic, or it's guessing what can happen in future, and deterministic is due to severe high degree radiation which happens over a short duration of time. The long duration of time due to low level of radiation causes biological effects like skin necrosis or leukemia in the person, and it can also cause genetic defects. And non-stochastic effects like severe radiation in a short duration of time can cause burns or even hair loss or alopecia, feeling weakness, etc. The next one is ALARA. What is ALARA? As low as reasonably achieved. To get best picture with minimum amount of radiation, with minimum number of shoots, avoiding as much as fluoroscopy as possible, and also the surgeon should be with hands up away from the image, is what is called as ALARA, apart from the protective measures we are using. Recently, I had the opportunity to publish an article about the radiation safety knowledge in Indian orthopedic community, and the study concluded that only about 70% of the people were aware of the ALARA, and those who knew about the ALARA, they were using the radiation safety protection, as well as they were using the radiation dosimeters. Otherwise, the people were little, the remaining 30% of the people who responded were little not informed well about the radiation hazards. So how one can control the radiation? One can decrease the time of exposure by minimizing the number of shoots at the fluoroscopy, increasing the distance of the surgeon from the source, and increasing shielding like using proper gear. And also one should practice hands-off technique, means the surgeon should not be holding a part or using passing a K-wire or a screwdriver and holding the hand near at the radiation beam. He should go away at least a meter when the radiation is being used. One should also use shielding techniques like skull cap, goggle, then thyroid guard, lead apron for the chest, lead gloves, as well as the lead skirt, because hands of the orthopedic surgeon is also very much exposed, though the radiation which can be received to the body is only 5,000 rams, but almost 70 to 80 times it can be received to the hand and feet. But one should protect as much as possible the hands also by using proper lead gloves. So you should take care of all the radiation safety gears which are available, and you should maximize the distance from the intensifier. You can use lighter lead gowns which are available, but they crack early and you should keep on changing regularly. And your back should be also covered if you are turning away from the X-ray site when the shoot is going on. Eye is the only organ for which the radiation dose gets accumulated over the years, so one should use the protective goggle which is available. Taking care of the lead apron is also very, very important. If you fold them, they crack and the lead will get collected at the lower part of the apron. So they should be properly hung. It should not be hung like this. It should be properly hung on a proper hanger. The best way is actually to make keep it flat on a table, but unfortunately, this is very difficult as it occupies the space. At least one should use a hanger and place them properly. And the people who are not scrubbed up, like the anesthetist and the other people, can leave the theater when you are taking the radiation. One should also have used the radiation dosimeter badge. I've been using since 1993. This is a passive badge, which is frequently every 3rd month we send the badge and the radiation is checked. It should be worn underneath the lead apron and the mid chest level. And I heard the lecture by Dr. Vikas Agashe sometime in 2010 or 11 in the YROC. You can see that till my radiation in 2017 was, my radiation in 2007 was almost 17 sievert units, milli SV units. But after hearing the lecture, you can see that the radiations have gradually come down from 17 to 3, 1.8, 2, like that. So I've started using all the protocols properly, and I am really happy that knowing this radiation hazards really helps you to take care while you are doing the surgery. Coming to few tips while doing a surgery: think before exposing whether it is necessary. Release the foot switch or the button as quickly as possible. Avoid continuous screening and the fluoroscopy. Think of primary beam as well as the scattered beam. Don't use the average too much if you are using a non-moving part like arm or leg. It should be kept at 2 or 4. Here is an example. Average is 1. This is the picture. 1 picture is taken and the image is displayed. 2 picture is taken and 1 image is displayed. Average of 4, average of 8, average of 16. You can see that by increasing the average in a still part, the quality of the image doesn't improve. Only when you're using for a chest, or probably when the patient is respirating while you're using for spine, you can use a higher average. Regularly, we orthopedic surgeons, to get good quality picture, keep it at average of 16. That is a unnecessary radiation we are taking. So keep the average as low as possible. I normally keep either at 2 or 4, and only rarely I go above. And you should not use unnecessary 16 or 32 radiation. Zoom also, when you zoom through the memory unit, it unnecessarily requires more of radiation, KV increases. So instead of that, what you can do is you can take the X-ray unit up near to the body, and that will give a large zooming automatically happens with the same amount of radiation. Then there is some problems. Don't use the auto of the KV selection mode, because it takes images at different KV, like 70 KV, 72 KV, 74 KV. Then if the body requires 100 KV, then lastly it goes to 100 KV and displays the unit. So unnecessarily the body gets exposed to at many KV before the final one is taken. So normally what I do is I just keep it at auto mode and take a picture, and I see the readings of the C-arm. If it says 100 KV, then I make it into manual mode and keep it at 100 kV and take the next picture. So with one single shoot you can take without the problem of exposure. So never use the auto mode without knowing how it works. One should position the C-arm, especially having a laser pointer in the C-arm itself helps properly, and you can take a proper position. The study done by Dr. Vikas Agashe et al. Showed that almost 1/3 of the C-arm shoots taken in the OT were unnecessary. In 5 cases where 541 shoots were taken in the study, 181 or 1/3, 33% were unnecessary. So we should try to avoid this unnecessary shooting. Don't shoot while the surgeon is moving the body. Once the surgeon is ready, he says shoot, then only the shooting should be done. And while moving the C-arm also, shooting should not be done. Then avoid metals, like here a cautery wire was the culprit. The image was blurred, whereas just by removing the cautery wire, the image got better. Many a time towel clip comes in the way, and that's the reason why we don't get the proper picture of the body we are taking. So try to use, instead of using a towel clip, try to stitch the draping material to the body around the operative site where you are using the towel clip. So that's also very, very useful to get good picture. Never ever hold the body, hold with the hand and take a radiation, because your hands gets maximally irradiated. Then don't shoot while advancing the K-wire or a guide wire or a drill bit millimeter by millimeter. You advance, stop, take a picture, again advance, stop, take a picture. That should be the method, so that your radiation can be reduced at least by 70% while doing this technique. So one should use radiation protection while using the CM. One should remember the time of exposure, distance of the surgeon, exposure itself of the primary as well as secondary beam, skill of the person who operates the CM also is very, very important. One should use all the protective shielding methods, and also one should use the common sense while doing the surgery. Finally, the radiation exposure can be reduced by proper positioning of the CM underneath the table, staying away from the direct beam, source at maximum distance from the patient, keeping the receiver as close to the body of the patient as possible. Do not overusing the magnification, not using the average mode too much. Then considering scattered radiation, one should use the lead apron, thyroid shield, and other safety gloves. Then one should keep the hands off out of the beam while doing the taking the picture, not to while exposing to the patient. Thank you very much. I thank the Maharashtra Orthopaedic Association also for this opportunity given to me. Thank you very much.
Thank you, sir, for a wonderful tips on radiation safety.
Chandak sir.
Yeah.
Shivashankar is here and you can ask him questions.
Yeah.
Yes.
So any questions from the panelists?
Yes, Shivashankar sir, Rajeev Raman here from Kolkata. Yeah.
Yes, Rajeev.
Yeah. Sir, what about sometimes the young guys, they use this CM in running mode. So what is your suggestion for them for putting guide wire or putting in K wire?
That's what unnecessary. When you're taking the fluoro mode, and it's always used in a static mode. Take a picture, advance the guide wire, take a picture again, advance the guide wire, like that. Never use the fluoro mode.
Shiva,
Yes, sir.
Yes, sir.
you have given good tips.
Yes, sir.
One more suggestion.
Yes,
To
sir.
handle the image, you should have qualified ortho technician, X-ray technician, who takes much more precaution than our boys who handle the image intensifier.
That's correct, sir. Very, very correct. They should know all the hazards of the radiation. Then only they will take care of these things. So we should, as a surgeon, it's our duty to train our people, because everybody may not be getting a qualified OT technician. So whosoever we train, we should give them proper training so that everybody in the OT is taken care.
You can send your
Shivashankar, this is regarding dosimeter. Sometimes you get readings from the BRC that your radiation is too much. Now you should not do radiation. So how much, whether they specify the timings, how much time you should not do surgeries under the CM, is that way?
Yes. See, in a short span of 4 weeks, a person can get exposed up to 20 millis.
Not able to hear you properly.
Sir, if you can stop your video, I think we'll be able to listen better.
Who, me?
No, Dr. Shiva, sir. Anyone
No,
else?
he is traveling, Chandak sir.
Yeah, so we are not able to
There
do
is a
that.
problem. We will go to next topic.
Okay.
So next, can I invite Dr. Prakash Sigedar from Jalna for his talk on transfer to ward recovery room after surgery. Please share your screen, sir. Yeah.
Yes. Is my screen visible, sir?
Yeah, we can hear you. Screen is visible. Please go ahead.
Yeah. Good morning, everybody. Respected President, sir, Secretary, sir, and all the senior faculties. I am happy to present the topic transfer and handover of the patient in operation theatre. I am thankful to Dr. Gadegone, sir, for giving me this opportunity to share my views on this topic. Welcome to the Veteran Surgeons Forum. OT is my temple. This is the part 3. Warm personal greetings to all of you from Jalna, and thanks a lot, MOA, for giving me this opportunity. It is said by Winston Churchill that your presentation should be like a mini skirt, long enough to cover the subject and short enough to arouse the interest. So I will try to keep both these in my mind while I'm presenting, and I will be finishing in time. So I will be going by some scenarios. So this scenario is seen in most of the times. The surgery is done well in the operation theatre, and when patient is shifted in the recovery room or ward, we find dislocation of the hip surgery done, and this is a catastrophe for the surgeon, and for some time the surgeon becomes very annoyed. So this is a scenario which is commonly seen most of the times in the operation theatre. Then second scenario, we put a drain tube firmly, but while shifting, the drain tube gets removed and the dressing gets soaked, or there are problems due to the removal of the drain tube. Such scenarios are commonly seen. Then third scenario, which is seen commonly, is removal of the catheter while shifting, and the dressing of the surgery gets soaked, and we land in a catastrophe. And even if surgery is done finally, we face the problems of infection and other because of the such scenarios. And the fourth scenario I have seen while I was in the residency, the tourniquet in place when the patient was shifted to the ward, and it was inflated, and it was noticed at the time of post-operative round, and then it was removed. Fortunately, patient did not suffer anything, but such catastrophes happen in the operation, in the ward or in the recovery room if the patient is not shifted properly. And maintaining the IV lines and central lines is very important. And if the patient is not transferred properly or shifted properly, we may have trouble in getting the IV lines or central lines out. And along with these orthopedic problems, we have a pulmonary embolism, and in fact, we must be alert about these complications in orthopedic surgeries. Strict watch on the vital parameters should be kept while transferring the patient to the recovery room and to the ward. Transfer of the patients from OT to recovery room with utmost precautions is very important because of such things happening. Another complication is hypoglycemia and other complications. Monitoring vital signs is very important while transferring and in the recovery room also, and checking basic parameters like BSL, SpO2, BP pulse, etc. is very important. So why this topic is important? Transfer of the patient from operation room to recovery room, and from recovery to ward or room to is a very important aspect in the orthopedic surgery. Little bit of oversight or mistake gives disasters. Many surgeries fail due to a wrong way of transfer in spite of doing good surgical work. Many patients can have life-threatening problems due to negligence in transfer from operation room to the recovery room or from recovery room to the ward. So the underlying principle of every transfer and handover is that it must be conducted safely and with the effective communication between all the parties concerned. The key to safety is thorough risk assessment and communication. All patients undergoing transfer must be risk assessed for clinical need during transfer and handover of the patient, and procedure and guidance. Transfer by nurse or midwife, who must also take responsibility for communicating information relating to the patient and their care, need to be taken. The registered nurse or midwife who is currently accountable for the care of the patient has a duty to ensure that appropriate information and handover is provided to enable this to happen. So definition of the transfer is transfers are defined as moving the patient from one flat surface to the another. It may be such as from bed to the stretcher. Types of hospital transfer include bed to the stretcher, bed to the wheelchair, wheelchair to the chair, and wheelchair to toilet, or from ward to the operation theatre and vice versa as well. So our concern is we are concerned about transfer of the patient from operation theatre to recovery room and from there to the ward. Even shifting of patient from ward to the operation theatre before surgery is very important for us as an orthopedic surgeon. Checklist of what needs to be done in both these scenarios is very important, and scientific evidence-based guidelines are in place for transfer of the patient in both these scenarios. The purpose of the standards to be provide an outline that healthcare workers in the perioperative setting can use to develop and implement policies and procedures for the safe transfer and transportation of the patient. The recommended standards is presented with understanding that it is the responsibility of the healthcare facility to develop, approve, and establish policies and procedures for the safe transfer and transportation of the patient according to the established healthcare facility protocols. The rationale behind is that the recommended practices related to the safe care of the transport of patients to the operation room and recognizing the possible hazards in order to prevent injuries to the patient and our department personnel as well. The recommended practices did aid in the ensuring the transport and transportation of the patient without tissue injury, avoiding undue physical and emotional discomfort, and avoiding severe alterations in the body temperature, respiration, cardiovascular reactions, including hypertension and tissue perfusion. The patient care concepts include the maintain dignity of the patient while transfer by keeping him or her covered, explain all the actions to the conscious patient about what is going to occur in the process of transfer, instruct patient not to move until the command is given to do so, give responsibility of giving commands to the patient to one team lead member while transferring the patient to avoid the confusion. There is a scientific evidence for all this. There are many papers on guidelines of transfer for the patient from operation room. There are guidelines from NHS as well and others for recovery room and the transfer of the patient from operation theatre to the recovery room and from ward to the operation theatre. Recovery room is the safe. It is said that recovery room is a safe island in operation theatre, and in the subsequent slides we will see where it should be, what are the requirements. And NHS also has given the guidelines for safe transfer of the patient, and there are recommended standards of practice for the patient transportation from Association of Surgical Technologies, and they have also suggested the standard operating procedures for transferring the patient and qualifications required for that also. The standard of practice one is it is the responsibility of the healthcare worker to ensure that the safe patient transfer of the patient from bed to the transport device is done. Then standard of practice two is it is the responsibility of the healthcare worker to safely transport a patient to the pre-operative holding area or operating room. And standard of practice three, it is the responsibility of the certified surgical technologist CST and certified surgical first assistant and circulator to safely transfer the patient from transportation device to the operation room table. So, and these are various competency requirements for the certified surgical technologist and certified surgical first assistant and circulator. They are followed in the Western world and maybe in the metropolitan cities, but it is very difficult to follow all these in the small setups. But these are for the information that this should be followed, and qualified person should transfer the patient at any given time. The important tips for orthopedic surgeon is that orthopedic surgeon himself or some senior resident should supervise the transfer of patient from operation room to the recovery room and from recovery room to the ward also. Taking patient in operation theatre from preoperative room also should be supervised by some responsible person from the operating team. All devices placed during the surgery like catheter, drain, etc. should be taken care of while the transfer. Checklist of things to do and standard operating procedures must be in the place at all the time. Recovery room. Recovery room is a very important place where, and it is a safety island in the operation theatre. It should be centrally located. Easy access to the all operation theatre should be there. Surgeon and anesthesiologist must be available easily. And qualified nursing staff and transfer personnel must be there, and the recovery room must be well equipped. Location of the recovery, it should be a central location, easily accessible to all the operation theatres. It should be well equipped. Qualified staff should be there around the clock, and qualified healthcare workers for the transfer are needed. Transfer to the recovery room, it must be done meticulously, and it should be done with the permission of anesthesiologist, whether patient is in the position to shift or not, under supervision of the surgeon or some qualified person in the orthopedics. Position of the limb, patient, etc. must be proper. Drains, dressings, catheter, IV line must be taken care of while transferring the patient to recovery room. Complications in the recovery room, medical complications like pulmonary or fat embolism, myocardial infarction, hypoglycemia, etc. can occur. Orthopedic complications like I said, dislocation, catheter removal, drain, blockage of the dressing, etc. and injection and anesthesia problems can also occur in the recovery room. So tips for the small hospitals, even though it is not possible to have all these facilities in our small hospitals, we can take care of the transfer. Transfer of the patient must be supervised by surgeon himself or some qualified senior resident. Utmost care should be taken about the drain, catheter, dressing, position of the limb, etc. Operation in the post-operative room, recovery room should also be done by a qualified person, and operating surgeon should be available in the premises during recovery time. Most of the times we do the surgery and we leave the premises or we are out of the station, and if something goes wrong, it is very catastrophic. Even best surgery done can be catastrophic if post-operative care is not proper. So take-home message from my presentation is transfer of the patient from the ward to the operation theatre and from theatre to the recovery room, and then ward must be supervised by a qualified person. Operating surgeon should be very attentive about transfer of the patient. Many catastrophes happen due to mismanagement during the transfer of the patient. Recovery room is the island of operation theatre and it must be well equipped. Role of qualified healthcare workers, anesthesiologists and surgeon are important in recovery room and safe transfer of the patient. Thank you. Thank you very much, sir, for giving me opportunity. Thanks.
Thank you, Dr. Sigedar. That was a wonderful lecture on transferring and many facets of it. So a question to you is, would you
Yes, sir.
base more on protocols or personal communications in transfer?
Along with protocols, personal communication is very important, and one person should be given responsibility of communicating with the patient so that there should not be confused. And the person who is giving command should be qualified one, or at least he should know all the things about the transfer of the patient. So communication is also important along with protocols.
Thank you so much. Any questions from the panelists? Yeah, go ahead, sir. Babhulkar sir, go ahead.
The patient to be shifted from OT to recovery room should be like patient shifted to ICU. And each and every patient should be seen by intensivist rather than anybody else. Intensivist might be physician or anesthetist, but all post-operative patients must go through the intensivist.
Yes, sir. Yes.
Okay.
Together,
Yes,
there
sir.
are some of the equipments which are available for safe transfer of the patient. Any idea about it?
Sauji sir, can I request you to mute your, there is a hindrance.
There are many equipments, sir, we should use for transferring the patient, like sidebars and you can shift the patient along with the trolley also to the operation theatre there, and that is very useful for safe transfer of the patients. Using added equipments or standard instruments is very useful.
Yeah. Okay. One of the very common problems faced by a patient is extreme pain while shifting a patient from ward to the theatre when they have multiple fractures and say fractured neck femur. So how do you take care of it?
They should be pre-operatively evaluated, or they should be given some pre-anesthetic medicine like sedation or some analgesic injection so that they have a little pain. And while care of the limb part which is fractured, it is very important. It should be shifted with least of the moment of the fractured part so that he gets the least pain.
Thank you so much for wonderful tips.
Prakash, sir.
Yes.
Yeah, please go ahead.
Yeah. Dr. Prakash, now in NHS there is a early total care. That is the, I think, concept for daycare discharge. So how do you decide what are the criteria on which we can plan? Yes, this patient can be discharged on daycare basis, because now daycare surgery is coming up in a big way.
In most of the cities and in even small setup also, daycare concept has been there, and especially the patients who go undergo arthroscopy of the knee or shoulder, etc., they are discharged on the same day. There are some protocols, and we should take opinion of, as sir said, intensivist or the anesthesiologist who is taking care. That patient is completely out of the anesthesia. There is no danger to the patient if we discharge such patient after a certain period of observation. And these all patients are observed in the recovery room before they are shifted to the ward. Once they are shifted to the ward, there are discharge, there are less likely chances that some catastrophe will happen. So that should be confirmed by the anesthesiologist and surgeon operating before discharging.
Thank you.
You said about internal deformity and internal rotation of the hip. Anytime you faced a problem where the hip got dislocated post-surgical?
I have seen 2-3 times that surgery was done good, but while shifting the patient, hip got dislocated and we have to do the close reduction and immediately we have to give him anesthesia also second time. So I have seen it 2 or 3 times.
For shifting such a patient, you would recommend a triangular pillow or something like that?
All the precautions should be taken. The distance between the 2 limbs, proper positioning of the limb. If you can put the triangular, and basically some qualified person should be there who will guide all the people who are transferring the patient. That don't do like this, don't do like that. So that is very important. This happens because of the unqualified person shifting the patient.
Thank you so much for a wonderful talk on a topic which is less discussed. Now we move ahead to the next topic, OT preparation of the next case and care of instrument from Dr. Pradeep Kothadia, sir. Please share your screen, sir.
Good morning, everybody. I sincerely thank MOA for giving me opportunity for this presentation. Really speaking, there were some lacunae also in my hospital, in my OT, between how you prepare the OT between the cases. So with this preparation of this topic, I realized what are the shortcomings that my theatre. And I'm really glad that I share this presentation with my all OT staff so that they will also become acquainted very well how to prepare the OT before taking into the next case. So dear friends, OT is my temple. I'm going to talk to you on OT preparation for the next case and how we are going to take care of our instruments. There are some guidelines which is given by the Kayak. It is from the Ministry of Health and Family Welfare, Government of India, regarding all healthcare systems. It is a book of almost more than 200 to 300 pages where all guidelines are given. Some of the guidelines are picked up from this book. So we know what are the types of OT. They are modular, non-modular, septic, and scopy. Is there any difference between the preparation of these 2 OTs? Many times we feel our OT is modular and there is no need to prepare anything. You just take out the patient, take another patient. No, practically every OT is same. Before taking, you have to prepare OT, every OT before taking the next preparation. This is a scenario 1 where after the surgeon instructs all his assistants to prepare the OT and he walks out for a cup of coffee or OPD or an indoor round. And the whole OT is at the OT staff. We don't know how they are managing. Sometimes, pardon me. Sometimes the Jhadu wali bike comes in the way and start taking out all the kachra from the OT. So the first thing is that you should not use the Jhadu and Jhadu wali bike in the OT. They should not be avoided. Always mopping should be done in the OT to prevent dust which is flowing into the OT. This is the second scenario where if the surgeon knows how to prepare the case between the OTs, he can teach his staffs and he can get the things done by standing there and do the things in a proper position. So this is the way the surgeon guides the staff if they don't know how to prepare the OT. The surgeon has to stand. And everything has to be kept in the respective containers. As we know all the biological hazards containers, whatever colors and the things that have to be kept in that container. So this is the second scenario. So I think we also should know something, how to clean the OT before taking next patient. However, there are some steps of cleaning the OT in between the cases. Safe handling of the soil linen. Second is safe disposal of the medical and non-medical waste. Cleaning of high-touch surfaces with disinfectant with proper concentration. Cleaning of operation table with disinfectants. Cleaning of operation room floor with disinfectant. Check with the checklist and proper inspection of the OT before taking the next patient into the OT. These are the steps everybody should follow before taking preparing the OT for the next case. The ventilation, if you have got a modular OT, the ventilation has to be kept on when you are preparing OT and the door should be closed. The nurse or the person who is cleaning the OT should clean hands, put on the gloves, wear OT dress, footwear, a cap and a mask before starting cleaning up the OT. The first step is safe handling of soil linen. We should not take out the linen from the table or other things, and we are in habit of putting something that and this should not happen. We have to just curl the linen and keep it in a laundry bag. All the linen should be kept in the laundry bag by proper handling. So collect and remove of the solid linen, segregate in the soil and dry linen, and they should be kept in the laundry bag. The step second is the safely handling medical and non-medical waste. If you got disposable things, you can put into the bags, plastic bags. If you don't have the disposable things like suction bottles, clean the suction bottle with good water, and then you can dry it completely. You can use some antiseptic solution to raise it, and then dry it, and then keep again inside. All these bags should be folded after once they are used. Always treat every bag of the waste as if it contains a sharp object. So you have to be very particular when you are doing cleaning of this. Next is cleaning of the OT. The cleaning of the OT should be with only a particular type of equipment and not with the jadu. That will clean. All the waste should be collected nicely, and they should be kept in a proper bag, in a proper solution. It can gather and pick up both wet and dry waste. After you are completely taking out all the plastic bags, refill the containers with color-coded disposable bags again for next things. Next comes about the disinfectant, cleaning of the OT with disinfectant. Use disinfectant in proper concentration for cleaning of different high-touch surfaces like lamps, OT table, OT floor, etc. We use bacilloid. Bacilloid is a nothing but it is a ethylene dioxide, dimethyl, and glutaraldehyde solution, and the concentration which is usually advised is a 1% solution. On this manufacturer, they give all the instructions onto their containers, how to use, in which concentration for what. Here you can see the instructions for use. For consulting rooms and dressing rooms, you can use 5%. For operation theaters and critical care areas, you have to use 1% for cleaning the OTs. Yes, and there are some other disinfectants also which are used. They are Bacilloid, which is a mixture of hydrogen peroxide and silver nitrate. The container always gives instructions in what concentration we should use that. Third step is a cleaning of high-touch surfaces. Use separate clothes for cleaning high-touch surfaces like lamps, trolleys, etc., and OT table. We use two different type of this type of clothes, and they should be folded 4 to 5 times one onto other. This is usually used to clean the lamps and trolleys. This is used to clean the OT table. Now, the first step, we start cleaning the on the lamp. You have to clean the upside of the lamp. Next comes the glasses of the lamp. Next comes where you put up your handle. Has to be cleaned with that. Every time when you are cleaning one surface, you have to unfold the your linen and again fold it and use a different surface. Then clean the trolleys with the same cloth. Then you can clean your C-arms. All the C-arms should be clean. All other equipments like pottery machines should be clean with the disinfectants. The next step is cleaning the operation room table. Then we use a different linen to clean the operation table. Same way. First, clean all mattresses, the pillows on the top of the table. Next step is take out all the mattresses from the table and clean the under the top of the table without mattresses, so that sometimes we see a lot of blood which is there, soaked blood inside. So you have to clean everything from the table. This is the way the tables are cleaned. Then the under surface of the table, and if you have got wheels, you can clean the wheels also. Next step is cleaning of the operation room floor. When you are cleaning the operation floor, you have to shift the table to clean the floor underneath the table. It has to be shifted before cleaning. Then you clean everything into the operation table. Here they say you have to use minimum 3 feet around the table. That is the mopping, the disinfector should be used, and it should be kept for at least 10 to 15 minutes. Let it get evaporated, and your OT becomes ready for the next case. After everything, you must check and inspect the OT. Everything has been done properly, and then you can take the next patient for surgery. Then a surgeon, if he wants to go, he can go for a cup of coffee after taking the patient inside. So the patient will start getting anesthesia, anesthetist will start inducing the patient. So this way, I think we should follow these rules when you are taking the patient or for next operation. Now the next stop of mine is a care of instruments. We have got multiple instruments with us, and we have to take proper care of these instruments. They call the instrument cleaning, care of instrument, they call as the instrument reprocessing. They have advised some steps in instrument reprocessing. There are 6 recommended steps for instruments reprocessing. First step, which is very important step, is cleaning. Second step is the inspection. Third step is the packing. Fourth step is sterilization. Fifth step is the storage and delivery. And sixth is the quality assurance. We'll go one by one. First step is cleaning. Cleaning of the instruments should be performed immediately after surgical procedure. Then you will be able to remove all the blood clots and the debris from the instruments. Quick cleaning removes blood, debris much easier and can minimize the corrosion, fitting or instrument staining. Autoclaved, uncleaned instruments are not sterile, so they have to be cleaned properly. There are some gadgets which are available, like ultrasonic cleaners are available. They produce microscopic bubbles and they collapse. This cavitation process is very effective in getting into serrations, box locks, crevices of the instruments and clean it properly. Even after this also, the cleaning has to, you have to rinse the instruments in the tap water and keep them for drying. Hollow tubes are a problem. There are many instruments of ours in orthopedics, they are cannulated. The hollow tube instruments are problem, you have to clean them properly. There are some microorganisms which are seen inside the hollow tubes. Sometimes they are with the biofilms, and the microorganisms with the biofilms, even though the steam comes, the biofilm will not be destroyed with this steam, and the microorganisms are saved, and your instruments will not be properly autoclaved or sterilized. So how you do? This is a step we do. This is the drill. First, you put a guide wire through it, clean it, take out all the debris. Then take a syringe, 10 or 20 cc syringe. Take either a good tap water and put water through this cannulated instrument. See, the water should come out. Once you rinse with the water, the next step is we have to just take air into that syringe, and again you put that air through the hollow tubes, so that whatever water is inside, it will comes out and it becomes absolutely dry. So this is the way we clean the cannulated instruments. Cleaning up the reamers, I think there are many reamers, they give some brushes. So you have to clean with the help of brush all these instruments, take out all the debris and things from the instruments. And then the same thing is again repeated by putting a water through it and air through it to get a dryness of these instruments. Once this step of cleaning is over, the next step is of inspection. Every instrument must be critically inspected after cleaning for residual debris or damage. Replace the instruments as needed. Never sterilize a dirty instrument. In addition, take instruments of proper function and lubricate those who have metal on metal action, like nibblers, bone cutters, artery forceps. Instruments with stiff joints could be a sign of inadequate cleaning, or they are repeatedly used. So throughout that instrument. Next step comes packing. After cleaning and inspecting, and the instrument become dry, then the instruments are packed in a clean and low contaminated area. Use sterilized pouches, sterilization pouches, sterilization wrappers, sterilization containers, or trays. Nowadays, people use a lot of trays. Instrument trays should be double wrapped to maintain sterility as per the wrap manufacturer's instructions for use. Instrument trays should be wrapped in a way that allows for sterile presentation for process items. Wrap pack should be sealed with 1 inch, 3/4 of inch or half inch sterilization indicator tape. This is for quality control. Be sure to include a chemical indicator inside as well as outside for that packings. The next step is sterilization. We know all that CDC recommends have steam sterilization better. So this way we need pressures. Other methods of sterilization are ETO sterilization. We many times use it. Then there is one, whenever the instrument falls on the ground, we need a flash sterilization. This is a flash sterilization. This flash sterilization has to be kept in OT only, and it can get you get a sterilization in a minimum time, and you can reuse that instruments. But one thing is very important, that in flash sterilization you can use sterilize the instrument, not the implants. Implant has to be sterilized with a high pressure only. The step 5 is storage and delivery. Sterile items should be stored in a manner that reduces the places for contamination. The shelf life of sterile package is event related and depends on the quality of packing material, storage conditions, and amount of handling. Sterility maintenance bags, dust covers may be used to protect items that could be subjected to environmental changes or multiple handling before use. Should be 2 to 3 miles stick and applied as early as possible after sterilization, after the item has been cooled. Any tray, any you can say drum which is open once, it is unsterile. You have to re-sterile it again. The next step is quality control. Chemical indicators, we know, we all are aware of all this quality control. Chemical indicators should be placed inside as well as outside of the packages so that we should know they are sterilized properly. The chemical indicators are available in tape, card, strips formats for use with all process. These devices change color as indicated for the process they are monitoring. This record keeping of this are very important, separate for autoclave, separate for ETO, so that we are very sure that instruments are sterilized properly. To summarize, dear friends, first talk is the steps on the steps of cleaning OT in between the cases. First step is safe handling of soil linen. Second step is a safe disposal of medical and non-medical waste in a proper way. Third is cleaning of the high touch surfaces after preparing a proper concentration of the disinfectants. Next step is a cleaning of the operation table, mattresses. Remove the mattresses and tabletop underneath the table and the casters of the table. Cleaning of the operation floor, shift the table, clean the floor, and at least you should clean 3 feet perimeters of the table. Check the senior person should check whether the OT is prepared. Leave the OT at least for 10 to 15 minutes and then take the next patient. The next talk was on instrument reprocessing. Cleaning, as I told you, is the most important step. It should be done as early as possible after the surgery to remove the debris as well as the blood clots. Second is inspection of the instruments for proper functioning, whether there is any debris remaining or not, or if they are not properly functioning, you can lubricate them. If they are stiff or not, either they are not cleaned properly or you have to throw that instrument. Third is packing. There are many things which are available for packing. Like some trays are there, some materials are there. Fourth step is the sterilization. High steam sterilization is the best method of sterilization as on today. There are certain ways ETO sterilizations we do. We do sometimes a flash sterilization. storage and delivery should be stored in a proper place and delivery should be in a proper way. Once any set is opened, any drum is opened, any tray is opened, it is unsterile. You have to sterile it again. And we must have indicators inside and outside for quality control. Thank you. OT is my table. Sincerely thanks MOA as well as. Thank you.
Thank you, Kothadia sir, for a wonderful lecture. That was wonderful with good tips. So may I ask you, what are your practical tips when you have a busy list and in between two patients, what are the minimum things you actually practice?
Sir, stop sharing first. Stop sharing.
Okay. The minimum things what I usually do, one is a proper disposal of water, disposal of medical, non-medical. Second is proper cleaning of your operation table and the floor. These things are the very important things. And if your time permits, even you can clean the lamps of the OT.
So these things you have changed after.
What is the turnaround time?
Yes, Abhyankar.
What is the turnaround time between the two cases?
It is minimum, they say it should take 20 to 25 minutes.
Practically, sir.
Practically. When they say 20 to 25 times, it takes that much time.
What you say?
I now after preparing this lecture, I have changed a little bit. It used to be 10 to 15 minutes.
Yeah.
Okay. Perfect. So the practical tips after preparing this talk, you would name them number 1, 2, 3, 4.
Yes.
For benefit of all small nursing home owners and for everyone.
The first thing, proper cleaning of the medical and biomedical waste, proper cleaning of the you can say suction bottles, which are very important. They are and suction tubings. They should be changed. Second thing is a cleaning of the OT floor completely. Then, if there is any blood clots onto the table, you have to clean the blood clots.
Okay.
And flooring has to be used properly, means with a sterile solution.
Many times we see sister cleaning the OT table with Savlon solution and a mop. So is that practically okay, or they should change to OT solution?
I think it's better to change to OT solutions.
Okay.
Because they can do in a proper way. Because many times we just go on to the theatre staff and they don't know what to do. So that's why I think it's better to train our theatre staff first, how to clean the things. And then you can go.
And NABH has really done wonders in all these protocols. Thank you so much, sir. That was wonderful. Any other question from panelists or suggestion?
Some of them still use alcohol as a surface disinfectant for instruments before going for sterilization. Is it advisable or practical?
Nowadays, this is not advisable. They say these are the proper solutions which use a proper sterilization.
Do you advise aerosol fumigation, quick aerosol fumigation? Because meanwhile, there were bottles were available when you were supposed to spray it around the air, and within 10 minutes, the OT is ready.
Yeah, but for that also you have to wait for 10 to 15 minutes. That also can be done. But this aerosol
after cleaning the whole thing.
Yeah. But this aerosol also sometimes causes a lot of erosions onto the C-arms and our lamps. So that's better to clean it. I think so. That will be better things rather than aerosol. Aerosol is for terminal cleaning. We call terminal cleaning. This my talk was between the cases. How you can between the cases. For terminal cleaning, yes, aerosol is very important. We must use aerosols.
Pradeep, can I ask you the question?
Yes, sir.
Please, sir.
Sir, I'm not able to hear you.
Is more. Maybe.
Sir,
can you repeat, sir? We were
not able to hear me?
Yeah, now
yes,
we can hear you.
The list is big.
Sir, I'm not able to hear you.
Babhulkar, sir, if you can stop your video, then you'll be. Girish, can you stop video from Babhulkar, sir, so that his voice is well heard?
Now, can you listen to me?
Yes, sir.
From the Pradeep.
Yes, sir.
When your list is more, maybe if you are operating 4 to 5 patients that day, it is difficult to follow all those instructions which you are given. nice instruction for 1 or 2 patient operations. But if the operations are more than 4 or 5, it is difficult to follow all these instructions. Your comments.
Sir, when the list you have got 4 or 5 lists, I think this hospitals will have at least 2 or 3 theaters, so that you can clean one theater, start case in one theater, clean the other theater. By that time, the second theater becomes ready. You can take the second patient there and start cleaning this theater. But if it is one theater, then sir, definitely it is going to be a little difficult thing. But these are the protocols. If you want to follow, I think that is the best thing if you can do that.
Can we have opinion from Vaidya madam for?
Yeah, in fact, I had one point which I wanted to kind
Yeah,
of,
please.
with due respect to all of you all.
Please go ahead.
One thing which I thought that the sir talked about the internal indicators, chemical indicators. So I really feel that these are the false indications, wherein these are process indicators which you put it in the, if you put it in every pack, it probably costs you not less than 2 to 5 rupees. Okay. And it's just going to give you an indication of the item has processed through. Whether the item is sterile or not sterile, it will not give us a indication. So we should rely more on biological indicators rather than all these chemical indicators as such. So that is something which I thought. Those maybe internal indicators are not required. We can process it in implants, definitely, but not in every instrument set, which will save our cost of, running cost.
Yeah, thank you so much. And in a busy institute like yours, what is your protocol of cleaning in between the cases? We find that it is practically difficult when the list is heavy. So your comments on that?
Yeah, basically you need to have your inventory management system well in advance. We have our list of operations. We know that a day before that next day we have these scheduled surgeries.
Okay.
And what are the instruments which are required for these surgeries. We know what is our inventory level. So I know that, okay, tomorrow there are 12 orthopedic cases and I have say about 7 sets. So I need to, give them time. After first case, they immediately rinse it and then it is sent to CSSD. And I know that, see, the turnaround time which we generally have, we have defined a turnaround time which is about 2 hours for any normal case. For laparoscopy instruments, it's about 3 hours. So if you define your turnaround time for instruments,
no, that
it
is
helps.
about, yeah, excuse me. That is about the turnabout time for the instruments and the sterilization. What I'm asking is, in between 2 cases, what basic cleaning measures you would recommend in a theater, or it is you can take the next case immediately?
Theater cleaning.
Yeah.
Theater cleaning, what sir has said is perfectly all right. Perfectly all right.
Okay. Thank you so much.
There's nothing to add on.
Okay. Thank you so much, Kothadia sir.
Thank you.
That was a perfect talk. So now we are waiting for the next talk from Dr. Abhyankar sir. And that's a very important topic for all of us. Sometime in life, we may face this catastrophic complication of a death in OT. And let us get the tip from none other than Dr. Abhyankar sir. Death in OT or death on table. Please go ahead, sir. We can see your screen. Yeah.
Yeah. With stalwart speaking before me and the not so happy incidents of death in operation theater, I would like to share my views on that. Death actually is a physiological process, but it is the most dreadest thing when it occurs to the cases in our hospital, be it more in the operation theater. As the popular belief, most of the surgeons would like to see that the case or the patient died due to anesthesia complications. But statistics shows that only less than 1% they die due to anesthesia complications. Most of them die due to high cardiac risk patients, old age people, what we as orthopedic surgeons usually operate on. Hemorrhagic shock in polytrauma patients where you are operating, trying to fix and save the limb or bleeding, trying to control the bleeding and all those. These are the cases. Embolism is one and anaphylaxis is the last. General surgery and obstetric and gynec have the highest percentage of operation table deaths. In orthopedics, as I said, usually it is the polytrauma or the negligence if you cut a major vessel accidentally. I have witnessed a case where a spine surgeon, orthopedic surgeon doing spine, ruptured aorta while scooping out the disc, and the patient died on the table. So as I said, death on table is the deadliest complication of all possible complications in medical field. And I'm not going to talk about how to prevent the death and all that, but we will be talking on what we should do when the death occurs in operation table. Now, what is the scenario? Scenario is usually of panic, confusion, and last, but very important, is mudslinging, putting the onus on somebody else rather than owning it ourselves. So what is the first and foremost natural instinct when the person is in trouble? Is call for help. So I would like to enumerate the way you should go about it. Call for help. You should call a senior trusted colleague, your orthopedic association or a local medical association person, your hospital boss, a non-medical friend who is always very useful, a henchman for legal, non-legal matters, and I have put lawyer in the smallest of the fonts, and he will be the last person you will be needing when the death occurs in operation theater. So calling for help. Now I usually show this picture when I am talking about doctor and the dead body in my talks. When you are caught in such situation, you call somebody, but to whom you should call is very important. Otherwise, the person who is calling you is going to give you trouble. So do not call anybody. A colleague who is your friend should be called, and everybody in hospital should know whom to call in such emergency situations. Maybe you will have to have a mock drill once in a year. Even there is no death or there is no complication, you can always ask him and call him for a cup of coffee when you are operating or the surgery is over. This is one video I usually show. It's not running, it seems. Yeah. So what happens is, when you are calling somebody, he should know what you are doing. Otherwise, this man, after he's running, is stretching out. And while he is stretching out, after his exercises, the other person comes in, sees what you are doing, and trying to help you. So your person who you are calling should know why you are calling him and what do you expect from him. Otherwise, these things happen. And you should always call an expert colleague while you are at it. Usually the death is imminent. In the operation theater, you come to know, you foresee it that it is coming, it doesn't happen suddenly, and an additional hand is always a welcome. As I said, we will discuss how to go about it. Usually you anticipate the inevitable. The patient and the anesthetists, the assistants, they will come to know and they will inform you that we are losing the patients. So what we should do as captain of the ship or the chief surgeon is inform the seriousness to the responsible mature relatives. That is where the relation between the relatives and the operating surgeon comes into the picture. I have seen many surgeons operating on patients where they have not seen the patient before surgery. Forget about meeting the relatives and all that. But I think you should make it a point that you meet the relatives and the patient before you start operating on him. I'm not talking this out of my personal experience. When I underwent a CABG, my cardiac surgeon never examined me before doing my surgery. So I summoned him up before surgery and asked him to at least let me see who is going to operate on me. So you should have a senior, responsible, mature relative where you can talk to him about the inevitable. Involve them in emergency management. Small nursing homes, you can ask them to get some emergency medicine. You can don't make them run around. Only thing is you can ask them to help you in doing small things, but not to make him run around the city. Let the unavoidable sink in gradually. So every 10-15 minutes when you are in operation theater, even if the death has occurred, you should go out, talk to the person. We are trying our hard. We are hopeful of getting your patient out of it. That has to be done. You should not break the news suddenly that your patient is dead. Relatives should feel that everything is being done. That is what is important. In my last 20 years of experience in handling the medical legal cases, what I have come to know is usually the patients feel that there could be something could have been done to save the patient. So that feeling should not settle into the minds of the relatives. Then only you can have a good night's sleep. The next issue is the cause of the catastrophe. You should discuss with your colleagues, your seniors who you have called, and decide in operation theater the cause of the catastrophe. Otherwise, what happens is, I will tell you two incidences. When a senior person was called to help out, the fellow came with a defibrillator in his hand, shouting around while entering the OT where the relatives were standing outside. Baju ho jao, I have brought the defibrillator and we will go inside immediately. What happens is the relatives, they are now suspicious that this operation theater must be not having a particular instrument and this and that. That is why the death has occurred. So such impression should not be
Girish, have you stopped listening?
There is some net issue, I think.
Yeah.
Yeah, there is some net issue, sir.
Video band
It is freezed. Yeah, it is freezed. Yeah, let me call Dr. Abhyankar.
By that time, any tips from the senior panelist? Babhulkar sir, if I can ask you by that time, if you would like to give some tips. It is some catastrophic situation which we may have to face sometime in life, unexpected. So any tips from you, sir?
No, we are not able to hear, sir.
Girish, you can stop the video from sir so that we can get a better voice.
I have stopped the video.
Yeah.
This situation can arise once in a while.
Yeah.
I think don't lose your courage. Try to involve one of the senior orthopod with you, maybe one or two, and bring an intensivist in the picture.
Yeah. I think Abhyankar sir, you are back.
Yeah.
Yeah. Would like to continue? Yeah.
You can see.
Now we can see, and please proceed. No problem.
Yeah, I lost my Wi-Fi because I had electricity failure.
Yeah. Please go ahead, sir.
So what we should do is come together and decide in the operation theater only that what can be the cause of the catastrophe. There should be no blame games. Otherwise, what happens is there are 2 or 3 versions which are given to the relatives and the outside people. So surgeon is the leader who should decide, and he should own the responsibility of whatever happens in the operation theater. If you survey the situation, what things you should anticipate is the medico-legal issue. So most common things which you are supposed to be having in the operation theater, you should see that they are available over there. I'm going to tell you the practical things, not the ideal things. So yeah, sometimes you may feel that what Dr. Abhyankar is saying, it may not be ideal, but it is the most practical thing to do. Getting the things which are not there in the operation theater. Don't bring it from the outside, but it must be there with you. There should be a checklist, because I have seen a few cases where prescription for oxygen cylinder was given to the relatives. This has actually happened in Solapur by an and by ENT surgeon. So this thing should not be done. Getting in the thing is, you are not supposed to prescribe oxygen cylinder to the patient, and in the case the ENT surgeon lost because the relative produced an oxygen cylinder prescription to the patient. The commonest thing, 2 cases where medical legal were decided on lignocaine sensitivity test. I know how many of us we perform the sensitivity test, but most of the orthopedic surgeries are done under spinal anesthesia, and we are supposed to have a mark of the sensitivity test on the forearm of the patient. So just check it. I am sure that everybody does it, but just check it that the mark is there on your forearm. Ventilator is the new thing in good old days. It was not expected of each and every operation theater to have a ventilator, but after decision of the High Court, even Karnataka High Court has gone to the extent of saying that there is no ICU available in the hospital. You are not supposed to operate. That is not going to stand in the Supreme Court, where the IMA has taken that matter to the Supreme Court, because you cannot have an ICU in each and every operation, each and every hospital where you operate on that. So these are the things you will have to see. You discuss with your colleagues and then come to one conclusion, and then you go out and tell the patient what has happened. Notes writing is one thing which I would like to advise. When you are operating, nobody expects you to write notes into minutes and seconds. I have seen doctors writing notes from 9 a.m. surgery started, 9:02 p.m. and 9:02 a.m., 9:10 a.m. and 10:30 a.m. or something like that. It is not necessary. You can start writing that the operation commenced at 9 a.m. and it finished at whatever time, 10:30, 11:30 and what. But you should refrain from writing minute to minute and second to second notes, because I have seen learned judge asking the doctor whether you were operating or you are writing notes. So that is the point which has to be remembered. Investigations, pre-op investigations, there is a certain protocol of pre-operative investigations where the X-ray chest is the included thing. It's an established fact. So everybody has to have a pre-operative X-ray chest along with the blood investigations, what we usually do, and an ECG after the age of 40 years. Post-operative or peri-operative investigations, if you are done, you are sending the blood for the cross-matching, you have brought the blood and all that, that record has to be kept. The most important thing is staff briefing, because you have n number of staff coming out and going out in the melee and the chaos when the patient dies in the theater. And each and every staff will give a different opinion outside, because these have a relation with the patient's relatives. A doctor takes around only for 5 to 10 minutes, but remaining 23 hours, these are the people who are with the relatives of the patient. So they have a bonding with them. And if each and every staff starts giving a different version of the death occurring in the table, so you will have to have a meeting of the staff also and brief them properly what is the cause of the death and what should be told to the relatives. Talk to the team as a whole once. Again, it is important to talk to everybody at one go. Don't talk to individuals in a separate group or independently or individually. Otherwise, as the joke goes, the communication is the interpretation of what you are talking to the people individually can get different. So it is better to talk to everybody at one time. All the relatives should be called once, and then the news should be broken to them, and whatever next is to be done is to be explained to them. While explaining or breaking the news, do not play the blame game. Like anesthetist was the problem, or this was not there, oxygen was not there, the electricity failed, because nowadays with the active judiciarism, every onus is on the hospital owner. Even if the electricity fails, it is the onus is on the hospital to have generators available 24 hours. Even I have seen a case where the generator also failed to start. The patient could not be saved, and the judgment even was that you had not done the annual maintenance contract of the generator. So the annual maintenance contract of monthly maintenance was not done. The doctor had to show that he had a monthly maintenance record of the generator itself. Then only he could come out of that case. So do not blame anybody out of pocket. Highlight how you tried the best. That I think should be done mostly. That we have tried to save the patient this way, that way. We called this expert. We have these machineries available with us. We have all the expertise in the world to tackle this issue. So you will have to impress on the patient's relatives that everything has been done to save their kin and kith. Do not talk of your shortcomings or mechanical failures, as I said. So you should not give excuses of mechanical failures or your shortcomings to the relatives. That is going to, just remember that you should know that the case is going to be a medico-legal case. Even if you have good relations, in the patient is 90 years old and all that, people nowadays, they are in a habit of going to the court against doctors, even if not to punish you, but to get some money out of you. So what should be the next thing to do? Shift the body to ICU or some recluse area if you don't have ICU. With the advent of the ICUs and ventilators, now it has become very easy. You need not declare the death in the operation theater. Most of our colleagues, they declare the death when after shifting to the ICU around 6 to 8 hours. That gives enough time to the relatives. The things sink in gradually, and the reaction, what we call, is usually a subdued reaction. Discuss the future course with the leader of the relatives. What happens is, once the death is declared, now people start talking about further course. You give us the body and we are going to go away with that and all that. But you will have to tell them that this is a medico-legal issue and you will have to inform the police. But just remember that don't inform the police before you complete the paper. You should buy some time, complete your papers first, operation theater notes, indoor notes, and your investigations. Because nowadays the police have also become smart. The first thing they will ask is to you is the papers. They are not going to wait till you write the paper and all that. So inform the police. I have seen a few times that doctor wants to not to inform the police, fearing that some police is going to arrest him and all that. But that is not the case. No police can arrest you unless the negligence has been proved by a committee in the district civil hospital or a medical college team. But even if the relatives have no complaints against you, inform the police, ask them, request them to get the statements of the relatives that there is no complaint against you. That carries a lot of weight in the law or the court when the investigating officer investigates and comes to the conclusion that there is no complaint from the relatives and there is no foul play or the negligence. Then only you can hand over the body. you can issue a death certificate, you are certain, because sometimes due to sudden cardiac arrest or anaphylactic reaction, patient dies and anesthetist is ready to certify, you are also sure that you have not done anything. These are the cases where sometimes the patient dies before you start surgery, or you just have taken a skin incision. So the complications of the surgery you cannot be accused of complications of surgery. In such situation, you can issue a death certificate, but you will have to have a evidence in your hand, maybe a recording of the cardiac monitor or a ECG, where it shows that the cause of death, what you are giving, is correct. Then hand over the body after informing the police, if police allows you to hand over the body, because once you inform the police, now the whole thing is in the hands of the law. Prepare a bill, but do not insist on payment. This is one thing which I have learned over a period of time, that doctors, or especially in corporate hospitals, the body is held, but in the latest 2021 Nursing Home Act passed by Maharashtra Legislative Assembly, it has been clearly written that you cannot hold anybody, a dead body or a live patient, because of he has not paid the bills. So prepare a bill, but do not insist on the payment of the bill, because if they go to the court, only if you irritate them, the expenses will be much more than what you are expecting as a bill from the patient. Never ever utter the word postmortem. Last month only, we had an incident in Solapur where postpartum, the woman delivered and she died after 2 hours due to PPH. The moment postmortem was uttered, there were 400 people outside the nursing home at the early hours of 2 in the morning. We, as an association president, I had to rush to the place, and what these people were from a specific community where the postmortem was a taboo. So never utter a word postmortem. Just say that we are going to inform the police. If the police insist, we will do postmortem, but we are with you. I am trying to avoid doing the postmortem, but if the legal requirement is there, I cannot help you. So this is the one issue where people become aggressive, where you are advising. So it is not the doctor who is advising the postmortem, it is the police who is advising the postmortem. That should be the idea given to the patient. So you don't insist on postmortem, it is not our job. With this, I think these are the things which we are supposed to do when a death occurs. There are many more things we can talk about, but the first and foremost thing is do not panic. Once you are panicked, as you know, when you go to your friend, when he calls you for tackling some complications, he tackles it in a better fashion, even if he is junior to you, because that fellow coming from outside is not panicky. The person who is operating has the responsibility, and that is why he panics. So the first advice will be, do not panic. These things as a doctors, we should take in the stride that complications will be there, including death for those who work. Those who do not work will never face this situation. The next thing which people worry is what happened to my practice, because there was a death in the operation theater. So don't worry, public memory is very short. If you have put in 10-15 years of your practice, you must have been treating the patients, and 90% of your patients get cured. So remember that only one death is not going to stop you practicing in the future. So public memory is very short. Now the last three thing is to have friends. Now you will have to have friends in fraternity, your own fraternity. I have seen the patient, I have seen my colleagues not attending any meeting, conferences, or going anywhere. So hardly they have any friends in the fraternity. People or the friends in the fraternity will be useful in such situations. So have friends. Have friends in police. Have friends in your lane. You should have a good relation with your local corporator, local dadas and social workers and so forth. So even if you are very good at your skills, you need to have friends in fraternity, police and society. Then only you can come out unscathed in such situations of operation table deaths. I think that should be enough for today. It is a very big topic. We can go on discussing, but I should stop here and would like to have some questions fired at me. Thank you so much.
Thank you, Abhyankar sir, for a wonderful insight into death in OT. And you gave a wonderful advice to keep friends in fraternity, have good relations with the family of the patient, and have friends in police, and manage the situation without fear scientifically. Thank you so much. Any opinion or comments from panelists?
Raju,
Yes, sir. Go ahead, sir. I think your internet is unstable. Again, if you stop your video, sir, we'll be able to listen better.
Sir, I have a question. May I?
Yeah, please go ahead.
Yeah, sir, my question is to respected Abhyankar sir. What we had in our knowledge was that when a death is happening in the hospital and when a death is occurring on a table, on-table death warrants an ethical committee which becomes a sub judice matter and is being appointed with the local or the regional dean that becomes the head of that inquiry committee or the ethical committee. Sir, is that still applicable today that any table on death will be become an EC matter? Or what I suggest is that we have had this experiences previously. It's not that we never had deaths in our hospital, but on table deaths were always being, the patient was being shifted to the critical room and the ICU, and we had always declared the deaths in such scenario always in the ICU and never on the operating table. Because in that case, what my knowledge was that in such cases the OT is sealed unless the entire matter is brought to justice.
Yeah.
Your opinion, please.
Yeah, that is why we should inform the police. The investigating officer in charge decides whether this case warrants an investigation or it can be closed.
Sir, if at all we say that the death occurred in the table or the OT itself.
Yeah. Even if, as I said, before taking the incision, after giving some drug, if the anaphylaxis occurs and the patient dies, you can very well give cause of death. And if the investigating officer is satisfied, see, the law depends on the investigating officer. It is not that every case or every death has to be reported and has go to the court. No, if the investigating officer says that this has to be investigated, then only it will be investigated. That is why we fear the police, because they have a lot of power. They have a lot of power. Each and every case need not go to the ethical committee. No.
Sir.
This investigating officer means which? Who is the investigating officer in this matter?
There is the nearest police station under which jurisdiction your hospital is.
So do you mean the PSI, you mean the inspector of that nearby police station will be an investigating officer?
Yeah, who is the in charge? Yeah.
Sir, I want to ask you one question.
Yeah, Gadegone sir, please.
Suppose if the patient has no complaints and he has been well explained that the death has occurred in operation theatre and he has no objection, still we have to inform to the police or not?
Yes. Sir, that is what I said. So you inform the police and ask him, request the police to get that no objection statement from the relatives. While investigating, what he will do is he will investigate by interviewing the people. So the relatives, if they give in writing, that happened in my case. My wife is a gynecologist. Stillbirth child was aborted and the patient bled to death at 11 in the night. It was an emergency case, but 14 of the relatives, including 2 lawyers in that, gave in writing that there was nothing wrong done by the doctors and we have no objection. That is why how we could come out. But I will tell you one thing, very practical things. Even after 14 relatives gave in writing, a case was initiated against me at the behest of somebody. But I could come out of it only because the police had statements of the relatives with them saying there is no accusation.
Dr. Abhyankar,
Yes, sir.
can I have two questions?
Yeah,
One,
please.
as on today, your theater must have cardiac monitor with
Yeah.
with a defibrillator.
Yes.
It cannot be possible to have ventilator, but
Yeah.
monitor with defibrillator is essential.
Yeah.
Second, you said that X-ray chest is essential.
Yeah.
If the patient has ankle fracture and we are operating, patient is young,
Yeah.
it still holds true that you should have X-ray chest.
See, the courts have their own peculiar way. A cesarean section patient, 21 years old, the court said that it was a negligence because the preoperative chest X-ray was not done before cesarean section. So it is always better to have hemogram and everything we are doing anyway. A chest X-ray for an orthopedic surgeon at least is not a big thing. You have X-ray machine with you, you shoot one.
It is mandatory now.
Yeah, because the courts are giving judgments like that.
Okay.
As
So
the
one
High
que-
yeah.
Sorry.
Yeah, as I said, the High Court, Karnataka High Court had given a decision that you should not operate anywhere where there is no ICU.
Yeah, Netra, please go ahead. You had a question.
Yeah. One query is that see, we all know that in court of law you need to show your documents, proofs, and all.
Yeah.
However, in the recent years of technology and all, are those digital documents or certifications or records valid or invalid?
Yeah, usually the judges, they believe in what you do, what you write, unless and contrary evidence is shown on the digital things. So you need, what I understand by your question is the investigations which you have stored digital, or you are talking about CCTV cameras?
No. The investigations or the records which you have digitally kept, rather than you can digitally sign also those.
No. It is acceptable in the court. No issues.
Acceptable.
Yeah.
Okay.
Unmesh, you wanted to comment?
Yeah, two things. With the COVID now all been through, all patients need to have X-ray chest because you don't know who had a fibrosis, who had trouble. And so X-ray chest is mandatory for all anesthesia, including spinal, I suppose, nowadays. And regarding the ventilator,
so the question by Dr. Babhulkar was, if the patient says 20 years old, still no other comorbidity, you would like to get a chest X-ray?
I've been told by a physician that always have X-ray chest because that is mandatory for cardiac, lungs, and all function together, apart from everything else. Because a lot of things can be picked up on X-ray chest by a physician, which can be harmful, like cardiomegaly, maybe something like that in young patient, which we don't know of. Okay, so I think X-ray chest is mandatory by all physicians for pre-op fitness. And with the COVID, I think it's must, sir.
And for a 20 years old, you will also get a physician fitness also?
I make sure all the investigations are done, X-ray chest. And if there is any query, then we can get a cardiology opinion.
Okay, thank you so
It's
much.
like an institutional practice.
And sir, I want to interfere in this.
Yeah, please go ahead and comment.
I am working in a medical. I am working in a medical college. I am a member and a president of many of this inquiry committee.
Okay.
So what Mahajan sir says, I disagree, because every patient, whether it is 20 years old or 15 years old, if you are doing a major surgery, X-ray, chest, ECG, and physician fitness is must. It should be on the paper. It should be on the paper. Without that, I request you to not to post any patients, because I face many of these inquiries. I do many of the such inquiry. Your paper save you. If your paper is good, any inquiry committee from medical college will not point against you. If your paper is not good, such as pre-op notes, operative notes, post-op notes, shifting notes, then consent of the patient, physician fitness, X-ray chest, ECG, if it attached to the paper, any inquiry committee from any medical college will not point against you. And this inquiry committee clean you about all the things. The suffering doctor will be safe. The relative will not object against you. So ECG and X-ray chest is must for all major procedures.
Dr. Chandak, to answer your query whether you would like to have a physician see a 20-year-old, the answer is an orthopedic surgeon is not supposed to know how to read a X-ray chest. So
medically,
something goes wrong, the people will not accept that orthopedic surgeon has seen the chest X-ray and given green signal. So it is better to have. It is better to have.
So there are certain things which are preached but are not practicable. That is what the scenario is.
Yes.
But in a suspected case or a patient where we are likely to have common problems, etc., we should get, in ideality, yes, we should get a X-ray chest.
Dr. Chandak,
And yeah.
as
Please,
on today, doing a physical fitness and X-ray chest for a young person of 15-20 years is not done routinely.
Yeah, that is what I said.
That is to be done.
Yeah. So,
But I request the sir, it should be done because that is a very important document. You are in a safe zone if you have done the physician fitness. Otherwise, you will land in trouble. Only in the minor procedure like close reduction, ECG, the hemogram is acceptable. Any operative procedure without physician fitness is not acceptable.
Dr.
you.
Lingayat.
May I speak?
yeah.
This
Go
is
ahead.
the
Saudi
last
sir, one
question.
by one, we'll have two opinions and then we move to next lecture. Please go ahead.
From my personal experience, I can tell you, I was saved because I have done the pre-operative investigation in one case. Small case you should not take lightly. Even removal of implant also, you must have ECG, X-ray test, and physician checkup. That is a must.
Yes.
Yes.
But one thing I can add, if there is, can I add you one thing?
Yeah, please go ahead.
When in the institutional practice, what is there? You have to send a call to anesthetist for or a physician first to get the fitness. Then the physician writes there, it is fit from my side, take the opinion of anesthetist. And if you see what are the investigations which are told by the physician or anesthetist, in that everywhere you will find the X-ray chest is always written at the top.
Yes.
Okay. So we all agree that common preoperative investigation should always be done, including
In all patients.
In all
And,
patients.
another suggestion is that, sir, you ask the anesthetic to put the notes on the paper. Most of the anesthetic, they are in a hurry, they give the spanner, patient out, they leave the theater. So should not do such practice. Ask the anesthetic to put the notes on the paper.
So it should be pre-op note, operative notes, and a shifting note.
Yeah,
Yes.
intra-op notes or pre-op notes. Every note should be there.
Abhyankar sir, very good message that you have given.
Yes.
That 4 thing you must do it: chest X-ray, ECG, investigations, and physician checkup. That's
Yes. Thank you.
That is the way to go forward. I think.
And pay the anesthetist pre-anesthetic checkup fee. That is the evidence. That is the evidence. So I always put a receipt. Pre-anesthetic checkup fee given to the anesthetic. Yeah.
So with a common consensus, we should give everything what a patient we should give for his safety. We should do everything for his safety, and our own safety we should investigate properly. Thank you very much, Abhyankar sir. That was wonderful talk, and we had a lot of good interaction as well. Now we move on to next topic.
Thank you so much.
On patients positioning in OT in common procedures. And may I invite Dr. Sarang Deore to please share screen and give his talk.
Good morning, everyone. Respected President, Honorable Secretary, and respected teachers on the dais over here. It is an honor and I have a privilege to share a small topic concerned to each and every one of us related to our everyday practices. Am I visible on the screen now?
Yes, you are visible and we can see your screen.
Fine, sir. Thank you. Fine. Sir, what I usually feel is
No.
Now we can see.
Yeah, fine, sir. Thank you. Sir, positioning of the patient, I feel, is one of the most important aspect whereupon a surgeon should not be frustrated at the end of the surgery. And I feel that wherever you are comfortable or wherever, if at all you are operating in your own OT and you are not a visiting surgeon at any places, then you should have boys and you should have your versatile, your anesthetist, your boys, and everybody should be so much versatile with absolutely what is the expected position of the patient to the surgeon, so that none of us have any anguish, or maybe none of us are unhappy during the operating room. The better the MBA, what we say, comfort for each and every person on the operating room, right from the supporting help right to the second assistant, first assistant, and even to the patient also. I guess this is a very important topic, and thank you, Gadegone sir, for alerting me this one. It's a very important aspect for the OT staff because it gives ease of operating to the surgeon. There is ease of assistance, comfort to the anesthetist, and there is most important, comfortable to the CM if it is required for the surgery. It's what happens if the patient is wrongly positioned or in an inappropriate position. And that what happens is that usually your surgery time is increased as the surgeon is not very much comfortable. He keeps on changing the position. If that all the CM is not positioned from a very comfortable way, then every time you have to move out your surgery, your trolley has to move away, your assistant has to move away to give the weight to the CM. So first and foremost, a best requisite for an orthopedic setup, there should be a very spacious room so that you are able to have rooms whereupon there is a comfortable movement for the trolley, for CM, for the table. If at all there are constraints of the OT theater, and I guess swapping the position of the table ends can also help rather than if there is a less movement for room for the CM. So if at all the patient is not properly positioned, there will be difficulty in surgery, there will be difficulty in assistance, there will be uncomfortable anesthetist, a difficulty to place CM, stress to the surgeon to accommodate the implant or instrument, and there could be a recurrent uncovering of the patient body parts if at all the patient position needs to be changed once it is already positioned. So an inappropriate, what would be the outcome of an inappropriate position? It could be a longer operative time with related all consequences, unpleasant outcome, undesired X-ray, unhappy surgeon, frustrated assistant, and ultimately time lost to everybody. So a best position is always a must. Rather, if at all if your OT personals are being trained, or if at all your position ke nahi abhi pura draping ho gaya, aap aaiye sir, then they give you a call in the cabin consulting room ki sir, everything has been finished and now you come. And once you reach and you realize, yeah, you are on, probably this was not the position you wanted, and now they have done the complete draping and painting and everything has been done. And then these are the situations where you have to still go in and do that. So I guess in such situations, we should redo the draping, redo the painting. It may take some time, but at the end of the surgery, you will have a good outcome. So equally important to have a perfect outcome, need to plan as a pre-operative measure, make your OT personnel versatile with your needs of positions. The anesthetist should know the operative position before he induces the patient. If you are a visiting surgeon at a new place, it happens at so many times because we have some outside people who come to our OT, and then our boys probably are not versatile as to what position he would require. So either he should convey, he should make sure that he reaches well before a time to get a desired position, or send his assistant to save his time. Today we will be discussing positions related to general orthopedic positions only. The exclusions in today's topic would be all arthroscopic procedures like shoulder, elbow, wrist, knee, hip, all spine procedures, all rather anterior cervical fusion, lateral vas fusion, posterior lumbar interbody fusion, or whatever related to spine surgery, and appendicular plastic surgeries, procedures or positions, because this may vary with subject to subject depending upon the needs. So I have not covered in this part. This is for general orthopedic surgeon. That was what I was being told, and so I have prepared accordingly. Above all, positioning would be covered in respective sessions. So for ankle, if at all, we are subjecting, we have patient for medial malleolus, solitary malleolus, a bimalleolar, distal anteromedial or anterolateral plating, or an ankle arthrotomy. So I guess this is the most appropriate position whereupon the surgeon is standing at the leg end of the table, and we have ample of room for the CM to come upon. If at all the CM is coming from your right side, you have an assistant on the left side. You can swipe vice versa also. If at all you have a room on the left side for the CM, you can have an assistant and a trolley on your right side. Next, these are for the foot operative procedures, whereupon there is a lateral malleolus plating, whereupon you are eyeing a subtalar fusion, where you have a subcalcaneum plating, a triple arthrodosis where you want to go for a calcaneum cuboid fusion, posterior subtalar osteophyte remover, or lateral approach to a Haglund deformity. I guess this is also optimum position where you can also use a roll, or you can use a goal, a rounded load under the dripping, or you can also use maybe 5 liters or 2 liters of IV bottles under the drape to keep a position optimum. If at all you keep the second leg or the operative leg straight over the other leg, then there will be difficulty in viewing the CM, and also you won't get a dead lateral X-ray, you will be getting an oblique X-rays. So positioning of the ankle absolutely parallel to the floor or parallel to the table is equally important to get a good CM view. In other foot procedure, whereupon we are eyeing like wrist joint fractures or supart fractures or small metatarsal fractures, small bone fractures of the foot, if at all you are eyeing for K-wires or small plates. I guess a supine patient on a supine position with an thigh tourniquet and a CM coming from the opposite side, you are having your assistant and a trolley on the left side, and you are still standing at the leg end of the table. So this is a very comfortable position, I feel. If at all we are going for posterior ankle procedures, whereupon we are eyeing for a posterior malleolar plating, there's a all the tendo-Achilles related surgeries, maybe a bumpectomy or Haglund deformities or distal third tibia, posterior tibial plating, degloving injury, a wheel spoke, cycle spoke injury. All this can be pretty well addressed in this position, whereupon the patient is pulled at the leg end and his ankle and foot is dropping. So you have on table, you have the options to give a plantar flexion or dorsiflexion to relax the TA depending, or simultaneously we usually place the entire patient on a blue sterile sheet, blue sheet, whereupon the patient is placed and the dripping is done, so that if at all required, you have to move the position with a patient a bit proximally. In that case, the entire blue sheet, if at all pulled like a Macintosh and something like that, so you can get a desired sustained ankle plantar flexion. And tibial procedures, whereupon we are eyeing for a solitary medial tibial condyle fracture or a posterior medial tibial condyle fracture, upper third tibial plating or MIPO for tibia, or maybe a medial gastroclap and something like that, or open medial wedge osteotomy. I guess this is one of the most comfortable positions with the patient still lying supine, and maybe a comfortable on table figure 4 where we can make out, but the leg cannot be made to make into the internal rotation, whereupon an external rotated position of the tibia is very desirable. For a true lateral view, you can always maneuver the CM. I guess everybody will agree to this. For other tibial procedures, whereupon you are eyeing for a posterior lateral plating, whereupon you are going posterior laterally to decompress the common peroneal now, or maybe you are eyeing to fix the posterior some osteochondrum or something at the posterolateral corners. If at all you are going for a PCL fixation, it's an ABL, we have to go in and open. So I guess this is a very comfortable position, whereupon the patient is lying prone. The anesthetist, of course, has to be told prior hand that the patient is lying to be prone, because at times what happens when the surgeon is in a haze and the patient is lying supine, if at all no sooner the anesthetist has given anesthesia, even before the drug fixes, the surgeon is in a makes hurry and he asks the anesthetist to rush. So at times there may be some high level of anesthesia, and still the anesthetist would be comfortable putting up a tube or managing the situation once the patient is supine. But that's not the story when the patient is prone. So the drug always has to be fixed. He has to make sure that there is no high rising anesthesia in the spinal. The patient is made to have prone. The patient's comfort is obviously looked for. And then the surgeon comforts come into second zone, whereupon after painting, draping or tourniquet, you go ahead for all the procedures. You are eyeing at the popliteal fossa or the posterolateral corner. In distal femur fractures, again, if at all you are going for a unilateral plate, lateral plate, or a distal plate, or a DFN nail, or you are going for a Hoffa's fracture or patellar fixation, a supine position, standard supine position is very comfortable. Few surgeons are used to operate distal and femur on a fracture table. We have other positions or options for that as well. But those surgeons who are very comfortable doing it on a non-fracture table or non-traction table, I guess this is a very gold standard method whereupon we can approach to almost all of the fractures of the distal and femur by this approach. For proximal femur fractures, obviously a traction table is a must. All IT fracture with all its variants, a subtrop fracture, maybe a shaft nailing, a fracture neck femur where you are going for osteosynthesis, or a dual fracture with a neck and shaft femur, or a core decompression, whatever the case may be. Now the thing is that here you can see that we are eyeing for a right hip in this case. This is a demo case, is not actually operative case, whereupon the left hip of the patient is being flexed, abducted and external rotated. So that gives enough room for you, for your CM to get in and get out from that position, so that the surgeon has a complete space over there, both on his right and the left side, so that he can go for his with his wires and implants and everything. Basically, a pubal post is what is avoiding the patient from getting pulled down. And simultaneously, if at all here is the right case, the right hand of the patient is being tied to opposite side over his chest, so that it doesn't interfere the surgeon while putting his nail and the rest of the implants. For hip procedures, standard for intracapsular neck femur, if you are going for any hemiarthroplasty, Moore's approach, this is a standard approach whereupon we use a backrest position. so that the patient doesn't droop. Or maybe if at all you are going for a THR or maybe extended Moore's approach for a posterior column or posterior fracture of the acetabulum. Hereupon, the surgeon is always standing to the back of the patient, and the first assistant is coming from the opposite side. Over here, or depending upon whether you have a fixed pendant or a rotating pendant, you can always move rest of the inventory accordingly. In this case, we hardly require a CM, but if at all you require it, it has to come in a lateral fashion, coming across the table. For hip procedures, whereupon we are doing a supine table fracture, I don't have this image over here. So modified Harding's approach, hemiarthroplastic, or those surgeons who are versatile with the THR or doing anteriorly with the modified Harding's approach, a simple straightforward supine position is what is desired. For pelvis fractures, for all the approaches like Stopa's, ilioinguinal or open book phalangeal approach and all that, still we have to have a very supine comfortable position. It all depends whether the surgeon is a right hand dominant surgeon or left hand dominant surgeon, what side of pelvis you are approaching. If it was a right hand dominant surgeon on the right side of pelvis, patient operating on the right side, you would be standing on the right side. And a surgeon who is a left hand dominant, and if he is still living on the right side of the pelvis, he has to be on the right side of the patient. For shoulder fractures, we can give a beach chair position. Those tables on those operative theaters where they do not have a beach chair position and head high can certainly be used, because if at all you are use an intrascalene block or a supraclavicular augmented block with sedation or a GA. So in that cases, even if the patient goes for head high after the anesthesia, that should not be an issue if a table doesn't go for a beach chair position. So for almost all the procedures like a GT fracture, if at all you are going at a display GT fracture or neglected display GT fracture, a surgical like upper third humerus, anterior approach to the humerus, maybe you're doing an arthrotomy, you are going for an open Pankart or a bony Pankart or open AC joint procedures. I guess this is one of the most standard procedures. What I usually make a point is that the shoulder is hanging, the entire shoulder is visible, and there is no table inventory that is blocking your view from the CM. As the CM is coming from the opposite side of the table. If at all this is the right side of the surgeon I am operating, to my right hand side is my assistant, to my behind or the left hand side is the trolley, and from across the table I am having a CM that is coming in to help me. So for distal humerus fractures, maybe distal third fractures, condylar fractures, or posterior plating, posterior humerus plating, olecranon fractures, or upper third ulna plating, I guess this is one of the most best procedures. In pediatric also, supracondylar fractures, few surgeons are used to operate in this position. Few surgeons use it with in a supine position, taping the proximal part of the arm so that they are able to move the distal forearm with the distal fragment. Lateral deltoid split approach is also one of the standard approach. Here it's in a beach chair position, whereupon we can see that for addressing the GT fractures, for open cuff repairs and AC joint K-wires, this form the standard positions. The neck of the patient is being turned to opposite side, and we have a CM that is coming from the opposite side of the table. The assistant is to my left side and the trolley is on my right side. So this is a very comfortable position. For elbows, we know that like for radial head fractures, radial neck fractures, operative release of the lateral epicondylitis, or maybe reconstruction procedures for the lateral, standard is supine position with a big hand tray. Not a routine hand support, it's a big hand tray or trolley that we have that is usually attachable to the table, and we get to position this. For the forearm fractures, the patient is still supine. We have the liberty to do a supination pronation on table, so single bone nailing plating, dual bone nailing plating, or a distal end plating or K-wire. This forms a standard approach. Hereupon, still we have the difficulty that we cannot have a CM coming from across the opposite side. So you have to have your inventory or your assistants either to the right, not crossing the table end, and we can have a CM that is coming from the opposite end, opposite to you, from the same side of the patient. Here, what at times what happens is that if there are constraints in the OT is smaller and the CM cannot move from the opposite side, then every time you have to get a trolley out, get the patient out, get the assistant away and get the CM inside. And that takes time and that cost mentally also to the OT personals. For wrist fractures, standard for all the distal and radius DRUG surgeries, maybe small bone surgeries of the hand, we can have it on a simple supine position. The patient is supine and the hand is outstretched on a hand trolley. I guess I missed the image over here. The clavicle nailing from medial to lateral clavicle plating or a cervical rib surgery, open procedures for AC joint. Of course, the patient is lying only supine. There's nothing very obvious about the position. But most important thing is that some tables, they are eccentrically balanced, some tables are centrically balanced. So in theaters where there are eccentrically balanced, I'll always make a point that you reverse the ends of the table so that there is a comfortable room for your CM to move across, so that the CM is able to guide you if you are doing a closed procedures for like nailing and maybe your cervical rib, whatever it is. Thank you. I'm open for questions, please.
Thank you, Dr. Deore, for a wonderful tips on patient positioning. Any comments from faculty members or panelists?
Sarang, stop sharing first.
I do that.
Okay.
Please go ahead with any questions or suggestions.
Sarang, Sarang, is there any
Sir.
role of sloppy lateral position?
Yes, sir, certainly. Sloppy lateral position we usually do for scapular fixation, whereupon that's very comfortable. If at all I'm operating the right scapula of the patient, would be giving a left sloppy lateral position, and that gives a very ease to approach the scapula right on the medial border also, if at all on to plate.
Okay, in most of the accidental fractures or ankle fractures, also this position is little bit comfortable, because in ankle fractures, if you want to do something on the posterior side and then you have to fix the medial malleus, I think the sloppy lateral position will be a little bit better position.
What we usually have that we have most of the tables which have 6 motors. So on table also, maybe you can tilt the patient. If at all the patient is already be draped in a pure prone position and you want a sloppy lateral, you are unhappy with it. Or maybe you are not able to reach to opposite side of the hagland, you are able to reach only from one side in that surface. If at all you want to reach on the opposite side, then that maneuvering of the table can help you. But obviously, as you also said, if at all I'm going for the posterior malleolus fixation and I want to see the distal tibiofibular joint, I guess that is also one very good position to approach.
Sarang, particularly in spine surgeries, one can do in lateral position, one can do in prone position. If you are doing in lateral position, it is very difficult for assistant and all. So what you will advise for which position? Which,
Sir, I missed your first line of question. Please, could you please repeat your question?
Yeah, for spine surgery, in spine surgery, it can be done in a lateral position. Many surgeons do it in a lateral position.
No, sir, I do not have any experience related to lateral position unless there is only a specific implant removal. Almost all the surgeries, if at all you are approaching for dorsal sloppy lateral, as sir said, that if at all you are going for costotransversectomy, something like that, then these are the only things whereupon a lateral or costotransversectomy procedures, we are going for thoracotomy and something like that. These are the things. For conventional posterior cervical procedures, you are going for laminectomy or posterior mass fixation. You are going for a PLIF or a lumbar fixation. Either we have a spine frame or usually bolsters, whereupon we make a point that the abdomen is hanging. I had few images, but I thought that that should be excluded because there are another 7-8 images that I added for the spine procedures. But sir, could you please elaborate me what procedures you would like to do in lateral positions for the spine?
It is particularly depends upon the surgeon. I have assisted many surgery, spine surgery in lateral position also. Basically, it depends upon how surgeon is comfortable. But in lateral position, there is a very much trouble for assistant and other people. So that's why prone position I think is better than.
So it all depends on your training career.
Yeah,
how you are trained.
The position of the spine was devised in the good old days when there was no suction and cautery when we used to operate on the spine. So in the lateral position, your field is very clear. The blood doesn't pool inside the spinal incisions. That was the reason. Once we had cautery and suction available, we have stopped doing that.
Sir, during our residency days, we used to have some surgeons who insisted for a knee chest position. So that was a very Dravidi pranayam to give a position. Obviously, we had a maquette at that time in the OT, so it was possible.
We also learned that in this knee chest position.
Gadegone sir, I would ask you a question. How do you brief your ward boys or OT boys to give position? काय
You-
सांगता तुम्ही त्यांना? What?
Just
how
give
do-
position.
Yeah.
Yeah.
What position you are going to
No,
need
no,
for a
no.
particular set?
Actually, in all positions and everything, it is the surgeon's preparation. I give the position, not my assistant. Because that is a practice, it's my small setup, and therefore some mistakes of the staff will reflect my operation theater, operation techniques. And therefore, I personally, before scrubbing, I see personal myself the position of the patient and then go for scrubbing. That is my protocol, may be wrong.
And it is right protocol. It is very good protocol.
Yeah. Rajeev, Raman sir, would you advise something on positioning tips, etc.? I think he's not. Yeah, he's okay. With this, I think we come to the next topic, and that is also a very interesting topic from Professor Lingayat. We'll have a topic on common instruments must in OR. So this is one really very interesting topic, and all would be glued to their sets while listening to this topic. So can you share your screen, sir?
Lingayat sir.
Did he get delinked? Lingayat sir, you are able to listen to us?
Lingayat sir, please unmute yourself.
He's connected. Lingayat is there.
Yeah. So Lingayat sir, Girish, if you can call him and just get him on board. By that time, any question is there, we can take up the question.
I am visible, sir? My
Yes,
presentation. Yeah.
Yes, Maruti. Share your screen.
Please share your screen. We are not yet able to see your screen.
Yeah.
Yeah, now we can see your screen.
Yeah.
You'll have to go to first slide.
Thanks, sir.
The checklist for all important instruments is really very important. Please go ahead, sir.
It is okay, sir?
Yes, yes.
Yes, sir. Good morning to everyone, or good noon to everyone. Thank you, MOA President Gadegone sir, Secretary Karne sir, and all MOA executive to give a chance to become a part of this important theme, which is generated by our President, Dr. Gadegone sir. OT is my temple. He has given me a topic, essential instrument in orthopedics. I tried to cover this topic in 15 to 20 minutes. So, lots of greeting from Government Medical College, Aurangabad. So, what is this essential instrument? This essential instrument are the instruments which make the surgeon task or procedure easy, which will produce the good outcome for the patients as well as for the surgeons. And to know the beginners, what are the essential instrument in the orthopedics or in the ward or operation theaters is must. To categorize this essential instrument, I categorize them into instrument in the ward, instrument in the operation room and CSSD, instrument in the operation room and surroundings, and instrument as such on the operating table. What are the instruments which are in the ward or a casualty? These are the common instruments which you use to remove or place the pins, wires, and sans pin in cases of external fixators. So what are the instruments which are needed for this? This is the simple our drill machines used to place the pins, wires, and sans pins, etc. Another things which should be there in the casualty or minor OT or in the ward are the all sizes of the Steinman pin, which is commonly used to give tractions before the patient is posted for surgery, or it can be used in cases of external fixator applications also. Different sizes you all know, that is starting from 2.5 to 4 mm size. Another thing which used to remove the external fixator or place the external fixator is a T-handle or a chunk. Other name for this is a chunk. It should be there. It is a very handy instrument. It should be there in the ward or minor OTs. Spanners, you all know that it is there to realign your external fixator, to remove the external fixator. Different sizes of spanner are available. starting from 3 size to 12. Commonly 5 to 6 is required for radius ulna, and 9 to 10 is required for your tibia and femur. Another important toolbox which should be there in the ward or casualty is a dressing box. It consists of needle holder, artery forceps, different sizes of blade, and suture cutting scissors. If you are starting orthopedic hospitals, one should have some certain splint in your hospital. This is a Bowler-Brown splint. You all know the advantage of the Bowler-Brown splint and how to use it. It is commonly used preoperatively to give attraction to the patients for especially in the lower limb trauma. Post-operatively, it can be used to reduce the edema also. Each and every hospital must not have this. But second one, that is a Thomas splint. I suggest that every beginners or every orthopedic surgeon who is going to start this hospital, he should have two Thomas splint, one pediatric and one adult, to immobilize the lower limb extremities traumas, which is useful, very useful things, how to calculate the length and everything you all know. This is simple wire splint. It is also useful to transport the patient from one place to another place or from wards to the OT. If you're not having a Thomas splint or a Bowler-Brown splint, you can use this wire splint also. Another things which is needed in the wards or the casualty or minor OT is the plaster removal instruments. You all know that there is a manual plaster removal instruments and the electrical plaster cutters. So these all consist of plaster saw, plaster scissor, plaster spreader. What are the instruments essential in the operation room in CSSD, that is Central Sterilization System? You all know that first part of it will be the attack-low. What should be quality of this attack-low? It should be good capacity attack-low, at least two to three drums should be attack-low at a time. Proper functioning should be there, and it should be have a proper monitoring system for pressure and volume. Malfunctioning detection device and alarms. In addition to this, I will suggest one should have a biological indicator to know that whether your sterilization is good or not. At least strip should be there. And apart from this, you should maintain the register as Kothadia sir shows in his previous presentations. For the beginners or in remote areas or small setup, it is another essential instrument, that is small boiler is useful for emergency surgery. You can boil so many things. I will not recommend this, but in emergency it has to one has to accept it. These are other handy portable attack layout for the beginners where the cost of establishment of setup is a matter. These are good alternative for fully automated or highly capacity attack tools. What are the instrument in the room and in surroundings? You are seen in the ward casualty, then in the CSSD, then what are the rooms? What are the essential instrument in the operation room in the surroundings, not in the proper operation theaters? These are portable OT lights. You all know that you all have having ceiling OT lights, but sometimes the ceiling OT lights are not working. They have some electrical problem. So you should have a side-by-side portable OT lights. They are very useful for minor procedures. They can be transferred from one place to another place. They can use in the minor OTs in ward also to do the minor procedures. Another things, everyone know that we have gone through the situation where pool of blood is there in the operative field because of having not kept in ready during these procedures. So I recommend you use a quarterly for the beginners. It starts from various prices, basically 25,000 to lakhs. So at least having a basic quarterly should be there in your setup. It may be monopolar, bipolar, underwater, anything, depending upon the affordability of that surgeons. It is very essential instrument one has to keep in the operation room. Another things is a suction machine, which is another important things which has to be kept in the operation theater while working in the surgery or in the positions where the blood keeps on accumulating or forming blood basins. This instrument or this machinery is very useful. I recommend to keep a two suction machine. One is an electrical suction machine or one is a manual suction machine, because sometimes because of some failure of electricity or anything, if you are not having this, then manual suction machine will be useful. And this not only useful for the orthopedic surgeon, this is very useful for the anesthetic also. When your patient want to come out from the general anesthesia, this is very essential things which is to be there in the operation rooms. Most of the institute having nowadays having a central suction systems, but for the beginners, I recommend that at least two suction machines should be there. One is a manual, another is electrical. Then you all know that the instrument in the operation room or surroundings is the manual tourniquet or automatic tourniquets. So I recommend to use the automatic tourniquet because manual tourniquet has their own problem to maintain the pressure and everything is difficult. And automatic tourniquet will have a post-operative complication or complication related to the tourniquet will be less. You all know that the operation table is there in the every theater, but you should know what are the attachments which should be there. That is bolster, stirrup, tighteners, belt should be there. We should check it. What will make it? It make the proper position and stable attitude of the patients and make comfortable for both patient and the operating team. So in addition to table, one should see that its attachments are there or not for better position and stable attitude of the patients. Lastly, instrument on the operating table or the trolley. What are these? I try to divide this instrument to the basic instrument, surgery specific instrument, and essential instrument. So what are the basic instruments? These are the hemostatic forceps, that is artery forceps or tooth forceps, plain and tooth forceps. Then other will be the Ellis forceps, Purchase forceps. We all using this commonly in our operation theaters. Then dissection scissors are there. They are used to dissect the plane between the muscles. They can use to cut the different structures like ligamentum teres, tensor fasciae lata, and they are also useful to do the debridement. You all aware of all these things. Another things which is there, which is important, which should be kept on the operating table is the different type of retractors. So retractor will be manual retractor, that is Langenbach retractor. They are available in different sizes. So starting from small to large, depending upon the which surgery you want to do. If you are doing the radius ulnar surgery or a small bone surgery, we also recommend to use the thyroid retractors. Then large surgery like femur surgery, you recommend a large Langenbach retractor. Homan's retractor, now people are most of the time using the Homan's retractor. It makes the surgeon's life easy. They can be used very well in all surgery, but they are recommended in acetabulum and other pelvic surgery. You can use in the femur, tibia, everywhere you can use these different sizes, angles are available for Homan's retractors. Another handy instrument is the self-retaining retractors are there. What is the advantage of using this self-retaining retractor? They make the stable and no fatigue retraction. Less number of assistants are required and it will give the good operative field for the surgeons. It makes the surgeon's life easy. So what are the different retractors which are available? You all know that mustard retractor, gel piece retractor, Norfolk retractors. These are self-retaining retractors which are available in the market. I recommended to use this retractor to make your life easy. So another things is the clamps which are we should keep in the operating room or in the drums. These are different clamps are there: ball tip clamps, towel clamps, serrated reduction bone holding forceps. You know that ball tip clamp and the towel clamp can use for the minor surgery like patella, medial malleus, lateral malleus, your olecranon process. The serrated reduction forceps holding can be used for the long bone surgery like radius ulnar humerus. These are the bone holders which are required for the doing the all orthopedic surgery. This is a Hay-Gross bone holding forceps useful in the femur surgery. This is bone plate holding forceps which is useful for radius ulnar surgery. Then other holding forceps are bone holding forceps, self-centering bone holding forceps. These are different reduction devices which is useful in the operating room. One should keep on the operating table. This is pointed reduction forceps which ratchet lock. Some are having a speed lock, and other is a Lohmann's retractor or Lohmann's bone holding forceps which is commonly used in cases of humerus surgery, radius ulnar surgery. I recommend to use this. You should keep in your operation theater. You all aware that different types of bone chisels, bone gouges, and osteotomes are needed in orthopedics. They are basics of orthopedics. Everywhere we require this instrument, that is bone chisel, bone gouges, and osteotomes. There are different sizes are available: curve, straight, etc. Another things which is required in the operation room or operation table is the different nibblers, cutters, and ronges. You know the nibbler is our backbone. In each and every surgery, starting from trauma to spine, nibblers are required. So different sizes nibblers are available. Different angle nibblers are available. Rogers are also available. They can use in long bone surgery. Specifically, they can use in the spine surgery. Then bone cutters, they used to cut the bones during the bone grafting, or they used to cut the spinous process during the spine surgery. You all are aware that we require the periosteum elevator also to doing the surgery, trauma surgery, then bone respirator, and then bore burr is also useful. Bone burr nowadays they are using motorized bone burr to to remove the bones, commonly done used in cases of laminectomy surgery or anterior cervical surgeries. Another handy instrument, if you keep in your OT, that is a femoral distractor, your life will be easy for doing a surgery like distal femur fractures or proximal tibial fractures. If you are having such distractor in your OT, then well and good. I recommend to use this femoral distractor while doing the surgery like distal femur or proximal tibia. It is his own choice. They are familiar with most of the surgeons. They are familiar without doing using this. So I recommend for the beginners to use this femoral distractor and keep aside in your operation theater. These are the jumbo cutters, K-wire cutters, and pliers. One has to keep. This is common, most common instrument needed for everywhere to cut the wires, to cut the pins. Then twisters, benders, wire passers is another handy instrument one has to keep on the operation rooms or operation tables to pass the wire while doing the insert class. Then tension benders are required to bend the K wires. Then wire passers is required while doing the insert class surgery. Another set of instrument which is required is the files, punches, and pushers and impactors. They should be there in operation table and operation rooms. These bone files, you know that how to use that. Bone punches while doing the radius ulnar surgery, you used to punch the nail inside the bone. Then skid is important. Bone impactors is also important. Different sizes are available. They used to impact the bone graft in the proper positions. Then bone hook is also required. Balls to hold the any bone which is come inside in your operative field. This while doing a surgery like osteotomy or amputation, these instruments are needed. This is a giggly saw or a electrical saw with various sizes blade. For the beginners, they can do the osteotomy or to do the amputation with the help of osteotomy also. But if you're having this giggly saw and electrical saw in your operation theater, then your life became easy. As these instruments are needed in the minority, they also needed in the operation theater also. That is Dunham pins, Chance pins, required for various surgery like orthodosis and channelized orthodosis or other type of orthodosis. Or your plan changes during the surgery that you initially you want to do the open surgery, plating or nailing, but once you saw the wound, you change your plan and shift it to the applying external fixators. So keep ready this Dunham pin, Chance pin in your operation theaters. You all doing the surgery like implant removal. So you keep the universal nail extractor. This is the Enders nails extractor, then interlocking nail extractor. If it is there, well and good. Otherwise, the implant supplier can supply this set of instruments. Or there is a universal plate removal sets. This consists of hollow mills, gripper, threaders, set for the extraction of the screws. So if it is available in your theater, it is your life became easy. So I recommend to use this, or otherwise your implant supplier will supply this all these instruments. When most of the things you know that our plan in the operation theater can be changed from one surgery to another surgery, or in cases of emergency situation, I recommend it to keep the set of square nail, J fixator or external fixator. If having additional Enders nail, tense nail will be very useful to do a surgery in emergency procedures or in emergency situations. You don't know that whenever your patient come and when what is urgency is there. For example, compound fractures are come, you have to do the surgery in emergency. For that purpose, you keep ready all the assembly of the external fixator, J fixator, or some radius ulnar surgeries there you want to do in the emergency. If you keep standby square nails in your OT, it will be easy for the surgeon to do the next jobs. So this is Enders nail set. This is tense nail set. This is rush or square nail set. This external fixator. Oh, yeah, the slide is not properly visualized, but you know that before doing any procedure or before shifting any patient to the operation rooms, I recommend to check the following things. Is a set of drill bit is available in your OT or not? You know that different sizes of drill bit are there. For example, 2.7, which is useful for radius ulnar, 3.5 for useful for TBI and the femur. I request to must be they kept in extra numbers. they can require at any time. Sometimes the implant supply forgot to put a drill bit in his set. So at that time, this drill bit will be very useful. It will not stuck up with your surgery. So I recommend you to keep the all sizes drill bit with extra numbers in your operation theaters. Then screwdriver, it is another important instrument. One has to keep additional number in the operation theater. And then check the tip of the screwdriver. Otherwise, you face the cold welding. Na aage jayega, na piche jayega. Or your implant supplier forgot to supply the screwdriver. In that scenario, also your own screwdriver will be useful. So don't forget to keep all sizes of screwdriver in operation rooms or operation tables. Then before starting any surgery, please check the CM whether it is working or not working. Otherwise, don't ship the patient to the operation rooms. Otherwise, you will land into you will be frustrated because if your CM is not working and you already shifted your patient to the operation table, and next thing will be very pathetic for the surgeons. So I recommend it before starting every surgery, make a checklist that CM is working. In that CM is an important part. Check it that whether it is working or not working. Take-home message for the most of the beginners or the new orthopedic surgeon. Essential instrument are the ornaments of orthopedic surgeon for successful procedure, which will affect the outcome of the patient and progress of the orthopedician. Sincere request to all to do the checklist before starting any procedure, major or minor. It will create less trouble to the himself or to the patients. Thank you, everyone. Now you can ask the questions if you have any questions are there.
Thank you, Professor Lingayat. And we'll have the question at the end. May I invite Dr. Unmesh Mahajan to please share his screen? That was a wonderful comprehensive list of all the required instruments.
I tried to cover that. I think I won't forget that pneumatic drill is not there inside.
Yeah.
So pneumatic drill or a manual drill should be there. So it is most of the theoretical lectures. So I try to cover everything is needed for the newcomers.
Yeah.
Thank you, sir.
So Unmesh, we are all keen to listen to your lecture, whether there should be a difference in the operation theater of a trauma OT and a replacement OT. Please go ahead, Unmesh.
It's a very difficult topic because I've been in a limbo where I do joints. So it's not any demeaning anyone as such, or trauma surgeon, anyone. I respect all trauma surgeons equally, because that's a very dynamic part to do in OT, is a trauma. And arthroplasty is a very routine stuff, 1, 2, 3, 4. Trauma always needs thinking. So all salute to all trauma surgeons, but here I'm going to talk on the basics, which may prick few people, but not intentionally, sir. Are the goals of an arthroplasty surgeon and trauma surgeon different? We want all happy and satisfied patients. We want healed fractures. We want full range of adjacent joints, unaided walking in due course of time, no infection, no resurgery till the end point, and all our patients should be our brand ambassadors. So the goals for joint replacement surgeon or trauma surgeons remain the same. They are no different. Why OT makes a difference? OT is the nerve center of our surgical setup. It's like our brain. Our brain isn't working, we can't work properly. Biggest enemy for any good outcome is the infection. And it's an emotional baggage for surgeons to carry at least for a few months till it settles down. OT setup and discipline is the majority responsible for infection. Trust me not, we are responsible for infection most of times, apart from minimum host factors. Gram-negative infection is primarily surgical induced because of poor autoclaving. Best practices will lead to a better outcome. Now, this is my fracture OT, and that's my joint OT. And there's no difference in setup because every patient is treated equally in my setup, because I believe all patients have to be equal. I can't differentiate a trauma patient as a bad patient or a poor patient, and a joint replacement is a priority patient. No. And a lot of people believe that actually. Why? I'll tell you why. We behave differently, inadvertently, not knowingly, but inadvertently. Because of Garbha Sanskar, I'll come to that. Some financial aspect, which may not be very worthy. Take it easy approach by many people. Why bother? It's not for us. A lot of trauma surgeons believe that joint is not my domain, so I won't do anything for OT because not for me. And denial of problem. Last thing is denial. We don't have anything, infections. Now, Garbha Sanskar, I'll come to it. Womb for orthopedic surgeon is a residency period. You are made orthopedic surgeons in a residency period, and he or she learns max in those initial years. Think of the days when your lecturer or a boss post a hip or a knee surgery replacement. He would make such a scene that the whole department is on his toes. Everyone's moving around, autocleaning this, autocleaning that, registrars cleaning the patient admitted for 3 days, bathing every day with a soap which he never had before, probably. All these things are done in the setup. But you ever remember you doing it for IT fractures in the setup? No. You've never been told that these are different. But this incidence is like a neck femur fracture going for THR and a neck femur going for DHS. These incidences make you believe that there are some special procedures and you need to take special precautions. We are never taught importance of asepsis in fracture as much as we've been taught in joints. And this stepbrother attitude continues in our practice because of this beliefs been put in our residency period. We've been told joints are different. Trauma chal jata, are tu bhi kar le, tu bhi kar le, tu bhi kar le. Joint, only registrars and the lecturer and boss will do it. And that too will have patient precautions. So our mind is tuned for those things all our life. Are the patient different? Yes, they are different. Arthroplasty patients are lifestyle surgery. They're elective surgery. Onus, because I tell the patient, I'll give you 100%. So onus is on me to get it 100% right. Patients are usually elderly and patient high expectations because they're paying more and they're Google educated. While your trauma patients are emergency patients not usually earned, but they come to hospital because of severe incident. Pain relief is the only expectation, initial expectation. No time to Google. Onus not on surgeon to give a result because circumstances might differ and scare relatives will not ask you many questions as much as they ask arthroplasty surgeons. But let's see the infection in trauma. Many believe that few dressings, oral antibiotics, pull on for 3 to 6 months, remove implant later, it will be okay. I think that's the general consensus for 80% population where, okay, some dressing is here and there, some pus coming, some drainage coming, I'm sure he'll be all right. In 6 months time, it will heal and we'll remove the implant and he'll be okay. Very few people will go down and debride in first few days or weeks. Very few people. I know they will do, but few people will understand that importance of infection coming into those things rather than joints. Now, this X-ray been sent by Dr. Chandak here, where a simple innocuous infection of the spine, of the femur with a small draining sinus. And this is a bad infection. And the last slide is of the joint replacement. So are these infections different? I think they are not. Because even for joint, we require 2-stage revisions procedure. Same thing will be for trauma. And what is the cost of reality of infection? In the stage 1, it will cost you 1 to 1.5 lakh rupees just for debridement, spacer, antibiotics, initial cement bags, surgeon, assist surgeon, anesthetist. Cost at home, you look at a cost at home, it's horrendous cost. Basically, consultation, pre-op fitness, cultures, gene expert, IV antibiotics depend upon culture. God forbid, if it's a gram-negative carbapenem resistant organisms, patient will have to spend 30,000 rupees per week for antibiotic cost. PICC line, regular follow-ups, physio, and revision surgery after 8 to 10 weeks. So the cost for any infection, whether it's a trauma or joint, is the same, maybe up to few lakh rupees in the end. So when it comes to cost infection, it is same for both and trauma patients as treated by world guidelines. This is reality. Don't escape that trauma is less costly than the joint infection. It's not actually, it's worst. Because trauma patients are mostly earning member of the family. It's very important. Most trauma patients are earning member of the family. Loss of work counts many folds. And sometimes permanent disability may lead to job loss. And this loss, we don't account into it. We only say they have been put up bill of 3 lakh rupees by hospital, 4 lakh rupees. But what they lost in job, the earning, the future compromise, and the loss of permanent disability can be very, very costly for them. So cost of infection for trauma is equally bad compared to a joint replacement. Financial aspect, a lot of people believe that arthroplasty surgeons earn more than the trauma surgeon. Far from truth. Surgical fees for a complex fracture is many times more than a complex arthroplasty. Actually, the more complex arthroplasty, they are more poor. And they end up having more discount than a standard arthroplasty. And implant in THR can be 50% of total cost, whereas in the trauma, it can be only up to 10 to 30% sometimes. So cost is not an issue, only is the mental makeup is the issue. And last important part is aha feeling. After a decade of practice, I'm sure all of you, on all of us, we don't work for money because we have money now. We only for name and fame. Aha is a feeling after good surgery which is priceless. And I'm sure good setup and no hiccups is the key for that. Good infrastructure and instrumentation like power system, etc., add a good spice to surgical exercises. Many surgeons have built up palaces, but they don't have spent on OTs. And that's the unfortunate truth. When people from the middle cities like district places saying, we are poor, we are small nursing home, we are small nursing home. They have palaces. I'm sure they have all palaces. But when it comes to setup, they believe there's a small setup. No, every setup has to be optimum for optimum patient. All setups should be geared to operate your mother and father and not someone else's mother and father. That's the important part. If you have a setup, you should be able to operate your father and mother. Make sure you operate other people's father and mother. Many good surgical outcome and early discharge reduces need for too many beds. So too many beds are no issues here. You don't require a 50, 60 bedded. You can have 20 bedded, but fast discharge because of good surgical outcome is far better. Should we discriminate now? Last point. No, we should not discriminate trauma and arthroplasty. No reason to lower the guard for trauma patients. Our efforts must be same for all. Since patient expectation doesn't differ in long term, all patients want to be perfect, happy and good. Happy patient is an asset with recurring interest like a fixed deposit. They will keep on getting patients, they'll keep on sending patients, and that's how your practice runs actually, by giving a happy outcome to happy patients. Investment in OT is the best for practicing surgeons, and who owns a nursing home should not think about why it's a small or big. The best is your OT should be the best. Give yourself the best like you give for a house, big cars, big things, big farmhouses. Feeling of pride in our own setup is very, very satisfying. Thank you so much. So we should not discriminate about anything inside the OT setup, neither the hospital setup, anything. Thank you.
Thank you very much, Unmesh, for emphasizing on a perfect OT setup and following the same discipline, whether it is trauma or orthoplasty. So any questions from the panelists to Unmesh? And then we will have a panel discussion of all the topics.
I congratulate Mahajan sir for an excellent talk. And one sentence was very heart touching. If you have an OT where you can operate your parents, you should operate rest of all of the patients. Congratulations. Yes. A wonderful speech.
Thank you so much.
Yeah, I wanted to include him because it's the most difficult topic. And he has made it so simple that there should be one uniform rule that OT should be treated as a temple, and it should prevent all complications which are occurring because of operation theater, whether it is trauma or in arthroplasty.
Yes.
So in all, the OT is the prime.
Yes.
My question or discussion about Lingayat sir. Initially, we used to purchase all the instruments and put it in our OT. Nowadays, there are sets prepared by every company for every operation. And the problem comes there. The person gives us a set and we don't check it most of the times. And the set is autoclaved, and on the table we see that there is no screwdriver or the screwdriver is not working, and the problem comes. So purchasing all the instruments, at least initially, is I think very important, rather than depending upon the company to send these prepared sets around.
So I recommend
let Dr. Lingayat answer first.
Yeah.
So my slide also says that in spite of your implant supply, you should keep this instrument ready with your operation in your operation theater. That extra screwdrivers of all sizes, and then drill bits which are handy. Then sometimes your plan changes, you can keep the external fixator also, and some square nails also. You know that don't know that in 11th hour you can change your plan of surgery. So these are handy instrument one has to keep in the OTs. So I request all the surgeons to keep ready all these sets of instruments, because you don't believe that implant supply will give a proper all things in the box.
Yeah, Dr. Deore wanted to comment, and then Unmesh.
Yeah. Sir, my comment to Dr. Sigedar sir was, if at all you completely rely on the vendor set, then at the end of the surgery you ought to get frustrated. The drill is never sharp, the jig is never going to match completely, and that is going to increase your operative time and all the related consequences. As Dr. Lingayat sir has emphasized, all the things you have to have at your hand, and maybe if at all you have some good numbers, you should have one of them extra, because probably that may not be articulate at the same point of time.
Exactly.
At all you are doing.
I
Many
recommend
times it
that
is
whenever the
practically
implant
impossible to
was
get every set available. So what are your practical suggestions to manage the situation? So the practical reality is we are called in to get loaner sets. So would you
Yes.
recommend any particular protocol?
Sir, so this is question for me, sir.
Yes.
Chandak, sir.
Yeah, go ahead.
Yeah.
Go ahead.
So if you are vendor supplying the things now, so my practice is that whether in a private hospital or medical college, I ask to resident to check all the things preoperatively before putting the set for the attack load. For example, if you are doing the femur nail, I used to check the drill jig also, and I have to check the holes whether they are matching or not. I used to check the drill bits available in the box is not. Then I used to ask to keep an extra screwdriver because you don't know that tip of the screwdriver is working or not. So if you do some practices, that is a preoperative checklist, which is commonly done in the institute. I think that there will be not any trouble while doing a surgery. So try to make a habit of making a checklist, that checking the instrument, checking the CM, checking the quartering machine, whether it is working or not, then checking the pneumatic drill, whether it is working or not, and keep one additional things. For example, your pneumatic drill is not working, at least a hand drill should be there. If your ceiling light is not working, your portable light should be there. Then CM, whether it is working or not working, twice you have to check it before doing any surgery, because it will reduces the fatigability of a surgeon and it will give a good outcome to the surgeon as well as to the patients.
Thank you, Dr. Lingayat. Unmesh, you wanted to comment? Please go ahead.
I think my logic is very simple. Three things you should always have is synthesis screwdrivers, drill sets, and clamp. Irrespective of what you use. And disinvestment in this manner is really bad, because a lot of people don't invest into instrumentation. So 5% of total income of a year, 5% only, or even 2.5% income, if you put every year into OT, exactly 2.5 or 5%, you will be a happy surgeon all your life, because that amount has to be replenished.
So you always must create a aha effect.
Sir,
that is good.
That is very important, because again, you are working for that part.
Yeah, Girish, your comments.
Mahajan sir to explain how much is 2.25 for him and rest of all of us.
No, actually, I want to share one thing. Dr. Senior Babhulkar, respected sir, is here. He has a habit of purchasing new sets from the beginning of his practice. So I want to hear from him what are the advantages of purchasing its own set of doing a surgery.
Wasudeo, I'm in practice last 52 years. Earlier, this loaner set was not available. So I had to purchase everything. From almost beginning, I have purchased all the synthesis equipment. Not one set, double set, triple set. So you should have everything with you and you should not depend on the vendors. At the most, as on today, you can depend only on the implants, not on the set. I suggest that you should have set yourself and then look only for the implants, which every time goes on changing.
Yeah.
And regarding the investment, I think at least 25% of your income, I'm talking income, 25% of income should go to the OT.
Should go to OT and Tamiya. OT and Tamiya, both.
Thank you so much for wonderful advice. Girish, you wanted to comment something? Please go ahead. I think we have lost Girish.
Yeah, see.
Yeah, Kothadia sir, please go.
Unmesh, your opinion regarding modular OT, whether it is absolutely needed, because in smaller setups, OT may be good. Whether it is absolutely needed.
Sir, it is need of the hour. And when I came to India from UK, I had only 7-bed hospital, of which mainly 3 beds more or less. But I had the best OT of that time, because I feel if I can have OT, I can generate more patients, sir. See, that's where the production happens. You can't have more rooms and poor OT. So better OT, less patient, and that's how you replicate. And that's the fastest growth part, is if you replicate the patient by less stay. So I think modular OT is, see, why we can't have a posh bedrooms? We go to 5 stars. Nowadays, we don't live in the 2-star hotel when you go outside, because we want clean toilets, clean room. Same thing for OT, sir. I think my point is everyone can afford it. The only thing is people have different priorities spending money somewhere. And that's a hard truth, unfortunately. So those people who love surgery, see, surgery is my life, your life, and sir's life. So our life has to be lived best. And that is our OT. If we are frustrated in OT and happy at home, which we hardly spend time, that's a wrong priority, sir. So my point is priority has to be right where your happiness comes from. If your happiness comes from OT, it has to be the best. That's it. That's it.
Thank you very much.
So now only 5 minutes are remaining so that we can important issues can be discussed and then we will go for vote of thanks.
Yeah.
Dr. Sandeep Biraris is here.
So any questions on any topics? We go one by one.
Thank you so much for putting this OT as a main fulcrum of our topic the last 3 weeks. Great. Great.
I am here, sir.
Yeah, please go ahead. Sandeep?
No, sir. Yes, sir, no problem, sir. I am listening.
Yeah, Sandeep, any questions from your side? Any suggestions or any comments?
No, sir. No, sir. It was a very wonderful. I have been listening all the talk.
Sir, Chandak, sir, I want to comment one. So I agree with Unmesh, sir, that OT should be our temple, which is our theme of our president. OT should be a very good OT. Surgeon should have comfort in operating in that OT. Other things are secondaries. If you have a good OT, your fatigability, stress is automatically reduced. It will give a good result to the patients as well as to the you. In addition to my instrument sessions, I want to, for the beginners or for new orthopedician, I recommend to use a 2 trolley in the operation rooms, one for the instrument, another for the implant. Don't mix the implant trolley or instrument trolley each other. So keep a separate trolley for instrument and for the implant. This also
perfect advice. Absolutely.
Thank you, sir.
Sarang, what do you want to say?
Sure. This is just adding. Probably it may be a revision for all of us who already have done that. See, we all of us have modular routines these days. My modular routine is just not that I put a laminar system and then I have blah blah walls and a good floor and I have a modular routine. That's not the story. Absolutely regular calibration of the OT is utmost important. You should have calibrated OTs. At regular intervals, you should have their HEPA filters changed. And by best, I guess, apart from having the measures, your fogger system has to be ultimate and error-free. The boys, I guess, you at all these days, you have biological indicators, you go for, you have a horizontal error-free system, whereupon you can go ahead and good some autoclaving and done and all that. But I guess you have your best of the boys doing the fumigation part of the OT apart from getting autoclaved. So regular calibration, regular changing of the HEPA filters. And if at all you have an HEPA system, which is not encompassing the entire length of the patient, then at least that part of the body, whatever you are operating, you see to it that is absolutely the table is adjusted so that it is it is just beneath the HEPA filters.
Yes.
That is just I wanted to add.
I wanted to add to it. Yeah, I'm audible?
Yeah, you can go ahead, sir.
Yeah, so I wanted to add that I don't know whether it was discussed or not, but regularly you will have to take the swabs from the
that is it. Very important.
Yes.
So I take swabs from my operation table floor, operation table, lamps, walls. So 5 places, and I do it every three months, and that is kept as a record for control of the infection. And most of the times, the swabs are negative, as far as I am concerned, for last so many years. One more question is, what about fumigation? How many of us do fumigation? I would like here to say that I have never fumigated my operation theater in last 35 years. It is only the air exchanges which I do. Any comments on that?
I think this topic was last time discussed in the previous session.
I was not sure.
Yeah, that was discussed. But any quick comments on that?
No, I just want a suggestion. After how much gap you want to change the HEPA filters? 1 year, 1.5, 2 years, 2.5 years.
There are different tests.
How many hours of running? What is your calibration? If your calibration is dipping, it is due for a change. For us, every 2.5 years, we change it, sir.
Yes, I agree with it. If there's an agency from Pune who does a calibration and give a count, partial counts. So the partial count is important. How much partial count you get, and then accordingly you should change your HEPA filters.
Okay. Question to Dr. Pradeep Kothadia, sir. You mentioned about sterility maintaining bags. What is that?
They have got different types of bags. where they have got different type of materials where they create the bags. Number one. If you are doing a ETO, then the plastic bags, you should not use only one bag. You have to use at least 2 or 3 bags.
Okay, you mean to say sterilization packs or wraps?
Yeah, sterilization packs or wraps.
Okay, perfect. And you also mentioned autoclaved unclean instruments are not sterile.
Yeah.
Autoclaved unclean instruments.
Unsterile, unclean instruments
are not sterile. So
Yeah.
the question is from one of the viewers. So can you please specify?
Means sometimes what happens, you don't clean the instrument. You just rinse it under the water. Okay, you don't see the instrument. You don't inspect the instrument. And you put it on the autoclave. So you're not very sure whether they're really done well. They are cleaned properly or not. Nobody does an inspection. So these types of unclean instruments are, even the autoclave, they are not sterile.
Perfect. Gadegone sir and Girish, if you have any
we'll
questions on your
conclude
WhatsApp,
now.
let us
Time
take
is
that.
over. Our time is over. They have given the signal so that we will conclude now.
Okay, please have your concluding remarks and what you have noticed during all these 3 sessions and webinars, and what are your take-home points. Please go ahead, sir.
So,
you want to share screen? Please share.
yes.
His dream has come true.
So it is just a thank-giving ceremony, nothing else. This is a Maharashtra Veteran Orthopedic Surgeon Forum. Sharpen surgical rationally, improve patient outcome. Therefore, OT is my temple, part 1, part 2, and part 3 webinar were kept. And these are all luminaries and faculties. They have helped us in the first webinar. GS Kulkarni, Vikas Agase, Dr. Gawale, Dr. Deshpande, Dr. Ajit Phadke, Dr. Babhulkar Sushrut, RM Chandak, Sandeep Patwardhan, Dr. Manoj Pahukar, Aditya Menon, and Netra Vaidya. In the next session, we have the Dhaval Desai, Rajendra Abhyankar, Dr. D.D. Tanna, Gawale, Chandak, Manoj Pahukar, Girish Motwani, Sanjeev Bhandari, Kiran Savji, Vivek Khadge, Abhijit Wahegaonkar, Sanjay Durjad, and Vijay Gangote. And on this today, all those who are on the screen, they help us. A very senior orthopedic surgeon, well known all over the world, Dr. Sudhir Babhulkar, has given us a chance, given time. It's a prestigious time, and Rajeev Raman also. And these are all Shivashankar, Pradeep Kothadia, Rajendra Abhyankar, Maruti Lingayat, Prakash Sigedar, Sarang Deore, Unmesh Mahajan. They have given their time, most important today, and RM Chandak, who has moderated this session very well. And none other than this, Artho TV team, Ashok Sham and Neeraj Bijlani, they have supported in this cause of Maharashtra Orthopaedic Association to spread the knowledge of OT is my temple. All authors are requested to write down in this, because we are going to publish this book, and those who are expert panelists also, they have to give their opinions on paper, and they will also be included in the chapters. So there will be 30 chapters of this book, and it will come through soon. Thank you very much for your your sharing and everything. I am very happy that all have helped us in this tenure. Thank you very much. Thank you very much, sir.
Thank you, President sir, for your vision. And wisdom
Congratulations to
continue.
Thank you.
Regards to all
Thank you very much.
the seniors, sir. Thank you, sir.
Thank you, Gadegone sir, and all the faculties. Thank you. Have a nice
Thank
day.
you.
And nice day.
Thank you, Gadegone sir, for excellent seminar. Very good.
Thank you, Wasudeo. Thank
Yes,
you.
sir. Thank you very much.
Thank you, Babhulkar sir.
आपने इतना समय दिया है, वो हमारे लिए बहुत अच्छा लगा.
Thank you. Thank you.
ठीक है.
Thank you, Raju.
Thank you so much, sir.
धन्यवाद
Thank you.
सर.
Thanks for your wisdom.
Thank you everyone. Thank you.
Supriya, yeah.
ठीक.
Thank you so much.
चलो बहुत बढ़िया हुआ.
हाँ, एकदम फर्स्ट क्लास सर.